This
Yes, so the
conference will
November
now be
exam
recorded.
is maybe just a few, more than a month away. All right. So let's first understand what exactly is going to happen in the online exam and the on-site exam. So how does the on-site exam differ from the online exam? So if you can see the image on the left-hand side, there are those many cubicles for the on-site exam. Okay, so you have your 14 stations which are held in 14 cubicles. So you know there is 2 minutes reading time and 10 minutes time for you to do the station. So what happens is there are 14 of you rotating between the cubicles. So you would get 2 minutes reading time at one cubicle. And if you can see my cursor here, there is a paper attached outside each cubicle. This is going to be your question paper. As some of the course candidates the other day were asking me about what exactly, where would the question paper be? Will we be able to see the question paper through the station, etc.? So yes, there is one question paper which is attached outside, which you would be standing here at the door during the 2 minute time to read this particular question paper. Okay, I hope you can see my cursor. All right. Once the 2 minute buzzer is done, you would be going inside. There would be your examiner and the role player sitting inside the cubicle. And there's a table here. If you can see here, there's a table here. So this table again would be having the question paper attached. So at any point of time, if you are confused, do not hesitate to look at the question paper. But yes, it is also important to have eye-to-eye contact with the role player. Okay, and you would be in such a you would be engrossed in the station to such an extent that actually if you do read the question well in the 2 minutes time, you would not have to look at the question paper again while you are performing the station, unless there is a lot of information and there are a lot of investigations attached, which would typically happen in a structured discussion. Okay, so this is how the exam scenario is going to be. So 14 tasks, 14 cubicles would be kept for you. All right, and there would be 14 of you rotating between cubicles. Okay, so this is how the exam would be, the online exam. All right, so yes, there would be certain stations here which would be different from the stations that we would expect in the on-site exam. I would be telling you about these, and at the end, I would be discussing the nuances of approaching a labor ward prioritization station as well. Okay, so what exactly is to be done? Okay, do not get overwhelmed with labor ward prioritization stations. It is actually simple. If you are practicing obstetrics, if you are dealing with patients on a day-to-day basis, it is not tough. Okay, it is not strictly based on guidelines. It is based a lot on common sense, and your prioritization as well depends a lot on the having a holistic approach, taking into account the patient scenario, etc. All right. So this is how the entire scenario of a online exam is going to be. Okay. So coming to how does the on-site exam differ from online exam? Okay. So of course, both the exam forms have pros and cons. The pros of the on-site exam, that is face-to-face exam, would be that there would be no connectivity issues here. There wouldn't be any eye strain or fatigue that usually happens with constant online exposure. Okay, and there would be a better display of expressions. Like if you are trying to empathize, your facial expressions would show better. Body language would also be appreciated in a better way. So those are the pros of an online exam. While the cons of an online exam is that you would be out of your comfort zone. Okay, you would be comfortable at home otherwise, so you would be out of your comfort zone. Of course, you would have to spend that much on traveling to that particular place and arranging for stay, etc. So that is there. And time in the station is not displayed. As far as the face-to-face exam is concerned, the time wouldn't be displayed. So what you need to do is you need to practice in such a manner that your biological time tells you when the 10th minute is going to get over. Okay, so when you are practicing, practice in such a manner that you know your history taking, your information gathering gets over at 4 minutes maximum, and then the rest of the 6 minutes is for you to discuss the management options. And when you keep on practicing it, you know, in the last 1 month, it is recommended that you practice at least around 8 to 10 stations per day. And when you do that, okay, take it from me, we used to do that. And like I was working, I remember, and I had applied for leave 1 month prior to my exam. Okay, so what we would do is I would study with Uma. So we would be practicing stations, okay, as we are cooking, as we are, doing our household chores, whatever, you just practice and practice and practice. That is the most important aspect of doing. And that is why it is important to have a study buddy for you. Okay, so it's important to train your biological clock to know which is the 4th minute and to know which is the 10th minute. Okay, and when you realize that you are reaching the 10th minute, don't sit and explain things to the role player. You have to finish points, because what the examiner is marking in the station is basically points. Okay, your scoring would be based on how many boxes are ticked in the examiner's answer key. So it's important to understand that. So for a on-site, that is face-to-face exam, you would need to train your biological clock, because you wouldn't be provided with a timer. Of course, in the face-to-face exam, there would be no break, unlike an online exam, which where you have break after the 7th station. Your first face-to-face exam, there would be no break. Okay. Then, okay, what are the do's and don'ts before you go for the exam? As everybody tells you, eat and sleep well the day prior, relax. Okay, you should have a presentable attire. A lot of people panic about what they should be wearing, what shoes to wear. It has to be, just remember, it has to be presentable. It is okay to wear whatever you think is suitable, which would make you presentable. Okay, and your shoes should be comfortable, particularly in a face-to-face exam, because you have to run between cubicles. Okay. Don'ts is, do not read till the last minute. In the last month, it is better to just practice rather than reading anything new. Okay. Do not rely on mobile or smartwatch for timer. Okay. And do not starve yourself. Okay. Eat healthy. All right. Then, okay. So some tips and tricks which have worked for all of us. Okay. And even our past candidates have told us that these have helped them. So one of the questions that is frequently asked is what is to be done in the 2-minute time. Okay. In the 2-minute time, remember, for the on-site exam, that is your face-to-face exam, you would be provided with a notepad, with a pencil. Okay. Now, whether to jot down points on the notepad, what exactly is to be written on the notepad, etc., etc. These thoughts would come to your mind the moment you have a notepad in your hand. Okay. Now it is a personal choice whether you need to jot down points, and whether you would look at the notepad at all while you are doing the station is yet another question. What I used to do, or what we did personally, is we just read the station thoroughly in the 2 minutes time that is provided to you. Okay, because it is very, very important to not misinterpret what is given in the station. Okay, it is very easy to get carried away. It is very easy to misinterpret what is provided in the station. So it is important for you to read thoroughly. And also you would be anxious. Okay, you would be tensed up at that time. Okay, so it is very easy to make mistakes. So it is important to read your task thoroughly, particularly in the 2 minutes time. Okay, and if you think you are comfortable with writing down or noting down things on your notepad, and then you think you would be, you can practice it while you are practicing station. Those of you who have face-to-face exam, who are answering face-to-face exam, you can do it while you are practicing with your partner. You can maybe in the 2 minutes time, you can note down points and then see if you're comfortable while you're doing the station to look at the points which are written down by you. Okay, so I was not comfortable to look at the pad again and again while I was talking to my role player. So what I used to do is I hardly use the pad for the exam. I actually had gone prepared, that thinking that, okay, these are the points that I will write, but no, that did not happen. So it's better that you read and understand the task thoroughly. That's important. Understand who you are. Now, many of us are practicing consultants. Okay. You need to understand that there in the station, you are the ST5, you are the registrar. So there may be certain controversial decisions or decisions regarding, say, complex surgeries, or like in urogyne particularly, which is a super specialty branch, anything of that sort. Okay. You have to involve your consultant. Although you may be a practicing consultant in urogyne, you may be a practicing consultant in infertility. Okay, but this is a usual problem for the first timers. You have to realize in the station that you are the ST5 and nothing more than that. That means you have to act like the registrar, like a resident, okay, in the station. So wherever there is anything controversial, although you think personally that, yes, I know my subject, but you would need to involve consultant whenever there is anything controversial involved. Okay. Then situational awareness. Now, what is this? The examiner will assess you based on the fact that how much of this particular circumstance or the particular situation you have understood, you have analyzed. Like, for example, there may be a case of a CTG tracing that is provided to you, which cannot be classified as, say, pathological. Okay, it may be just suspicious. All right, but at the same time, the patient may be having a small baby, SGA baby, or say a patient may be having some bleeding. Okay, so you need to take the decision based on her overall picture. Be aware of the situation you are in and don't just go by CTG. There may be other situations like not clinical situations, like the patient has come to see the consultant. It is provided to you that the patient has come to see the consultant, and you start talking to the patient as if you are the consultant and you are basically here to address her problems. No, okay. It is important for you to address the fact that the consultant is not here, and I'm sorry, I believe you were here to see the consultant. However, he couldn't be here. Is it okay if I carry on the discussion with you? That is how you should start. Okay, so that is your situational awareness. Then assess the role player's mood. Okay, many a times you would be taken aback when the role players start screaming at you the moment you enter the station, and then the entire station is basically botched up. Okay, because then you are anyway tensed, and then the role player is screaming at you, and you forget everything. So that can happen. So have an idea of what the role player's mood is going to be by reading the station outside. Like, for example, you are about to talk to the husband of a patient who's undergone a hysterectomy, and you had to do the hysterectomy on an emergency basis, and because the patient was bleeding, etc., etc. So you could expect an angry husband there. Okay, or it is given to you in the station that there is so and so who is waiting for you for the past 2 hours in the outpatient department, and now you have to talk to her about a particular problem. So there you can expect that the role player is going to be angry that she's been waiting for so long and nobody's attending to her. So you can actually think of what exactly you're going to say. Like, for example, if there's somebody waiting for a long time, you would not go there and ask, you would say that I'm so and so. You have to introduce yourself. That's more important. And then you would just ask her, so is it okay if I, no, you could ask her name and age, and then you ask her what is it that you do, etc., etc. If you keep doing that, like how you do other stations, she's going to yell at you and say, see, I'm not here to answer all those questions, and I'm already fed up because I'm waiting for such a long time. Please come to the point. She's likely to say that, and then you will get scared. Okay, so what you need to do in such a situation is have an approach where she cannot get all angry and basically react the way she is otherwise instructed to react. So what you can do is you can go in and you say, is that so and so, is that Anna Johns? Okay, is it okay? I know that you can start by saying, I know that you've been waiting for a long time and I'm really sorry. So start with an apology. When you start with an apology, there is no room for the role player to scream at you. Okay, so how would you assess this? You would assess this if you have read the station thoroughly and properly. All right, so that's important. Then identify clues in the task. This is very, very, very important, particularly in labor ward prioritization stations, which a lot of candidates miss, and which is why you do not realize that there is something hidden or there is some extra information that the task would offer you. Like, for example, let me give you an example. It is given to you that there is a patient with von Willebrand disease who has delivered half an hour ago. That should strike you basically, because you know that a patient with von Willebrand disease can bleed heavily. Okay, so the question that you need to ask is, when you are prioritizing your stations, you can ask the examiner, I would also like to know, okay, these are my urgent cases. However, I would also like to know if the patient with von Willebrand disease is bleeding heavily or not, because that is a clue that is provided to you. Okay, and a lady with von Willebrand disease is expected to bleed heavily, and PPH is a dire emergency. There is nothing more urgent than PPH, not even a pathological CTG. All right, so these are certain clues, certain subtle things that are mentioned. Like, for example, there would be a patient in early labor with floating head. Why would floating head be mentioned if there was nothing extra there? That's a clue. That is something that you need to pick on, and that is for you to realize that there may be something there, something more which is given. Otherwise, what is the significance of floating head otherwise? Okay, maybe CPD for which, or malposition for which you have time to assess, etc. There is nothing urgent that you would like to do. So why is this particular thing given, additional information given? Because there may be something more that would come your way. Okay, so such a thing that came in the exam, basically there was extra information that is provided, that she leaked and there's cord prolapse. Now what you do? Okay, so these are clues. Please, when you're going through the labor ward board, pick these clues. Very important. Okay, then have a holistic approach, as I told you about the CTG. Okay, it's you have to take the entire patient scenario into account and not just treat the CTG. Okay, then if there is a patient who's having say social issues, and she's having some problem for which you need to admit her, you need to take into account her social issues. Maybe she's a single mother, or maybe she's having other problems, or maybe she's having addictions, etc. So you need to make arrangements for her, to look after her child, etc. So basically you need to take into account the whole patient scenario, rather than just specific dealing with the specific patient problem. Okay, that may not be correct. All right, so that's important. Part 3 exam. Patient specific approach is again the same thing, is basically one form of treatment may not be suitable for another patient with the same condition. Okay, like there is a patient with who is having say morbid obesity. She is menopausal, she is not sexually active, and she's having say a prolapse. Okay, there you may think of something like a colpoclysis, rather than going ahead with all those surgeries for prolapse. You may think of a simple thing like colpoclysis. So have a patient-specific approach in your mind. Think about what is it that you would do for that particular patient. You cannot offer her all the treatment options that are available otherwise. Like for example, in fibroid cases, there is a lot of treatment options. There is medical, there is surgical, there is then there is your embolization, etc., etc. So now, if there is a big fibroid which is obliterating the cavity, and there is infertility, here you're not going to talk about medical treatment. You cannot be talking about, there are various options. There is medical, there is expectant, there is surgery. You know it is surgery. Okay, of course, you need to talk to her about the pros and cons of surgery, how surgery may or may not help her infertility, etc. But you cannot be talking about medical treatment for a big fibroid, say a 16-centimeter fibroid in an infertile woman. You cannot be talking about medical treatment. All right. So this is how your approach to the task would change depending on the situation. So in the face-to-face exam, as I told you, there should be a judicious use of the notepad provided. Judicious use, I said particularly because you cannot be scribbling anything and everything on the notepad. If you do that, you're going to lose time. In the 2 minutes time, you're going to lose, say, important information that would you otherwise would need to register. Okay, you would basically not register the information if you just keep scribbling in your notepad. Okay, it is important to write what is most important, maybe in bold letters, in capital letters, but don't keep writing, this is what I'm going to ask, that is what I'm going to ask, this is what I'm going to say. No. Okay, so that is why I said judicious use. Then scan the tape. This is very important, which most of you who haven't answered the face-to-face exam wouldn't know. Scan the table where the station is going to be held for props, consent forms, or set forms, etc. Like there would be consent taking stations, okay, where you have to go in and take consent. The task would be take consent. You have to pick up the consent form. You have to fill in the consent form. Okay. You may not get time to write all the frequent risks and serious risks and everything. You would just ask the patient. I mean, as you're telling the patient, you would scribble on it as you're talking to the patient about the risks. You would scribble on it. But it is important to write the patient's name, maybe NHS number if it's provided to you, or you can just write a number, and then you have to sign the consent form and then offer the patient the consent form for her signature. This is very important. So scan the table if there are any props kept. If there is anything kept, that is for you to use. Like there would be a station, say, knot time. There would be a suture material kept, or there would be, say, gloves kept. You need to wear your gloves and then proceed with the station, depending on what the station is. Okay. Whatever the prop is that is kept in the station, please use it. Please pick it up and use it. Okay, there would be the forceps teaching station. Forceps would be kept. You have to take the forceps in hand. You have to show her the parts. Then you have to offer her the forceps for her to show you the parts. Okay, so that is how it differs from an online exam. All right. If there is normal labor mechanism to be taught, there would be a pelvis and a baby kept. So you would need to show how the labor proceeds, progresses. All right. Then, okay, so this is important. Have eye contact with the role player. Don't keep looking into your notepad. Don't keep fidgeting. Don't keep looking at the question paper which is attached on the table. Looking once or twice is fine, but don't keep repeating it. Okay. Then avoid gesturing. Okay, so and that needs practice. And I would tell you, I would do a lot of gesturing. That is basically hand movements while talking. Okay, that gets very disturbing and it distracts the role player as well as the examiner. An examiner is going to concentrate on your gesturing more than what you are saying. Okay, an examiner, remember, is sitting there and listening to so many people doing the station, 14 of them in one circuit. Okay, in the on-site exam, so it is very easy for the examiner to miss things. Okay, so do not do all those hand movements that we normally do when we are explaining things to the patient. Okay, avoid doing it. Again, this requires practice. Okay, keep your hands on your lap. Okay, and this requires practice. Take it from me, because I used to do it and now I have given up. All right, then after the 10th minute, when the buzzer rings in the station, Do not wait any longer, no matter how important a point is missed, because whatever is said after the 10th minute is lost. Okay, anyway, it's not going to gain you any marks. And if you sit there after the 10th minute, then you're going to lose time, reading time for the next station, because your 2 minute time for the next station starts when your 10th minute ends for the previous station. So you get up and move to the next cubicle as soon as your 10th minute is done. Okay. So how would the stations differ? I have almost covered this. So your teaching task would have demonstration of props, consent taking, you would need to probably sign a consent form, and labor ward prioritization stations would come in different forms. Okay. All right. So then coming to the labor ward board. This is something that we all are waiting for, and we all find it difficult to do these labor ward stations. So now if you are provided with the labor ward board, what is it that you're going to do? Okay. The first thing is know what is asked. Now remember, there are variations of the stations that can come. Okay. What is important for you is, of course, you would need to know the domains covered in all stations. That holds true for all stations. Now, the important part is the task. Okay. What we used to do is we used to read the information, the domains first, then read the task. What is the task that is given at the end of the station in the question? Okay. Your task is to blah 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 blah. Okay. So know what is asked. Why am I saying this? Because there are different variations of station. One station could be such that you are given the labor ward board and you are seeing the consultant or you're seeing the examiner, okay? And you are asked to prioritize your stations depending on urgency and speak about immediate management. That can be one type of station, okay? Which you can expect to come in the on-site, that is face-to-face exam, okay? Because when you have prioritization stations, it is likely that they would be giving you information about the station in the labor ward board, and they would say CTG attached, MEOS chart attached, and there would be a separate paper which shows the CTG, which shows the MEOS chart. Okay, so it is for you to look at the labor ward board and then look at the paper, which may be quite difficult in an online exam, although they've had such exams before. But it may be difficult to do it, and it may be unfair for the role player, I mean for the candidate, to go through so many things on the screen. It would be unfair. So now the last few exams that they had, these labor ward board stations, basically what they would do is they would give you a single line in each of the rooms describing the room, describing the patient, and then they would ask you, then they would give you orally extra information, and then you would have to talk about the management based on the extra information that is provided to you. What we had was, when we answered the on-site or the face-to-face exam, is we had prioritization. So we had many charts attached, then the labor ward board attached, and then they would write CTG attached with arrows pointing to the CTG, etc. So then you have to look at the CTG, interpret it, and then decide which is priority. Okay, so that is one type of station, prioritization station, and it will be given to you that you have to prioritize. The word prioritize would be there. All stations are not prioritization stations, unlike what is usually commonly thought. Okay. The second type of station is you have to just go through the labor ward board and tell the examiner your immediate steps, which is an easy task to do, and which is what had come in the last two exams in May and before that. Okay, so they are not difficult stations. They are actually easy stations. Why they look difficult? Because you are facing a big list of patients. Okay, but if you practice well, if you know what to do in emergencies, if you know what to say and how to say in emergencies, you would easily get through those stations, because most of our past candidates who had taken the course have told us that they could finish the stations in 8 minutes. Okay, so it depends on how you say things, how you practice, what way you practice is important. Okay, so then Yes, so as this is what I said, that you have to understand that the station can come in various forms. So know what is asked and that it can come in various forms. Another form of station that can come is where you have to talk to the midwife and you are taking the handover along with the midwife. If you're taking handover along with the midwife, you have to basically discuss, like you would discuss with your colleague, okay, this is what we need to do, this is what we need to gather. Okay, so again, that would be, and that this is what I want to do regarding the allotment of tasks to the team. So the approach is going to be different, and this is something that you would not otherwise understand unless you put unless you pay attention to these minute things that are mentioned in the task under the station. Okay, so after that, yes, so in face-to-face exam, there would be multiple sheets which would be kept, as I mentioned, and there would be a paper for prioritization. For our exam, there was an arrow outside the cubicle which was pointing at a big paper which was kept on the floor. You have to pick up that paper and you have to write your prioritization on the paper. And you do that in 2 minutes. How do you do that in 2 minutes? I'll tell you. Okay. So in the 2 minutes time, you read the task carefully. As you are reading the task, you jot down the task, like you write, you're reading, you're looking at the task, and in your notepad or in that paper. Okay, it is easier to do it in the notepad. I would recommend that you use the notepad. As you are reading, don't look at the notepad, but you write 1, 2, 3. So basically, you're writing the rooms: room 1, room 2, room 3. And when you're reading room 1, against room 1, write urgent, that is U. Then if it is not urgent, you write non-urgent, NU. If it is semi-urgent, you write semi or SU. Okay, so 1, U. 2, you are reading SU. 3, you are reading NU. That is how you do it. Okay, what happens then, the advantage is when you go into the station, you can look at the notepad because you're talking to the examiner, you're not talking to the role player. So you are it's not about communicating in a sensitive manner or empathetic manner, etc., etc., that is happening. You're just talking to the role player, to the examiner. So here you can take your time, go through what you have jotted down in your notepad and pick up the urgent rooms, U rooms first. Pick those rooms and start talking about those rooms first. The urgent, this is in the prioritization. Remind you, there are different variations of stations. I'm talking about prioritization station. So pick those U rooms and start talking about U rooms. This is important, very important, because typically room number 10 or room number 9, the rooms at the end would have an urgent patient. So if you don't pick up the urgent rooms first, and you say that after finishing the station, I will prioritize or whatever, then it is quite possible that you would spend a lot of time on the first few stations answering unnecessary things, and you would leave out your urgent room where there would be a lot of things to say, and the maximum weightage would be for the urgent rooms. Like if there is a major obstetric hemorrhage in the room number 9 and you don't reach room number 9 because you are going room by room, you have not realized that it is urgent, then you would be just wasting time till room 8 talking about things that are not very significant, that are not going to fetch you marks. Okay, I mean, you would get marks, but you wouldn't be ticking a lot of points. Okay, so it's important for you to pick up the urgent room. So use to be picked up in the beginning. Okay, so that's important. Then yeah, so of course, another important thing is when you have not finished your tasks, reading your task in the 2-minute time, or you're confused, you can sit there after the 2-minute buzzer rings and ask politely the examiner for permission for you to read a little more, a little longer. I did that in my exam. Okay, I couldn't finish my reading my board, and it was a lot, and there were many charts attached. And I asked the examiner, is it okay if I take a minute to read? Okay, not more than a minute to read. Okay, and then I talked about the urgent rooms. I did not get time to finish the non-urgent rooms. Okay, but The thing is, if it's okay if you don't get time to, if you don't mention things about the non-urgent rooms because they do not carry much weightage in the station. Okay, so like patient waiting for induction, you would just go and say, I apologize, do a CTG, send routine investigation, consent, and wait. That is all that you're going to say in the non-urgent rooms. Okay, so it's okay if you don't get time to complete the station, the non-urgent rooms, but urgent rooms you have to, otherwise you would not pass the station. Then, yes, so read the rooms well and look for clues and expect hidden information as I have already mentioned. Okay, so like the von Willebrand disease station and the floating head, these are clues which are mentioned there. Okay. Basic principles of routine obstetric practice, whatever you think you would do in that situation. Okay, you are good enough to manage your patients, remember that. Okay, so whatever you would do in that particular situation for the patient, you have to be talking in a practical manner. Don't go by theory strictly. You have to have a practical approach to labor ward prioritization stations. Okay. This is important. Even if it is given to you that the CTG is pathological, okay, mother's life will always take priority over the fetuses. Okay, so if there is a pathological CTG in one room and there is a patient who is in PPH and shock in the other room, your priority is go to the patient with shock. Okay, because the lady with pathological CTG, you would still need to do a few things before you take the decision to deliver. Like you would probably do an FBS. You would try your conservative measures. You would actually see that the CTG is actually what it is interpreting, because CTG can be false positive. I mean, it can be falsely non-reassuring. So that is why it is repeatedly said that CTG should not be treated alone. Okay, you have to take into account the whole picture of the patient, and you have to do a few things before you take the decision to delivery. So if there is a PPH, go to the room with PPH. Okay, mother's life would take priority. Then check who you are talking to, whether it is midwife or the consultant. Approach to the station is very different when you're talking to the consultant or you're talking to the midwife. Okay, know what time of the day it is, because if it is 8 o'clock in the morning, there may be, it's possible that and you need help in the labor ward board. It may be given to you that the consultant is not there, consultant is stuck in the traffic or something, but your previous duty consultant may be there on campus because it's handover time. Okay, then you can say that I would ask if the previous duty consultant is available. All right, so that is how you would go about it. Okay, know who all you are with. All right, so this is your team, you should know, because your assigning of tasks would depend on your team. All right, then there may be special circumstances that they would be given to you. Make a note of those, like there would be no NICU bed given or consultant is running late, as I mentioned. So if there is no NICU bed and you know there is a patient in preterm early preterm labor, threatened preterm labor, you'll have to talk about in utero transfer. But if she's in advanced labor, yes, you deliver her and then transfer ex utero. But if it is given to you threatened preterm labor, you have to assess whether you need to transfer her in utero, because there is no NICU bed available. And so this information given in the station is frequently ignored by candidates, and it's important to make a note of this. Okay, this is how you write. Okay, in your notepad, 1, 2, 3, 4 till 10. Usually there are 10 rooms. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Then you write 1 urgent as you are reading. Okay, you don't even have to look at the notepad. You read all your time. You are reading all the 2-minute time you're reading. So 1 urgent, 2 non-urgent, 3 semi-urgent. This is how you're going to write on the notepad. Okay, so then all right, so now we'll do a station, and I want I would do it in a different way. I would like to split the station into parts. Okay, so let me show you what exactly would happen in the 2-minute time and what exactly would happen in the 10-minute time. How are you going to say, and how are you going to prioritize? So I would need 3 volunteers. Okay, anybody?
Can I please?
Okay, okay, Dr. Salma, Dr. Umaira, who else?
Ma'am, Manikam.
Manikam. Okay, fine.
Thank you.
All right, so I'll give you your station and I'll give you the your 2 minutes time. I want to see what all you do in the 2 minute time. Okay, let me check the station. Okay, yeah.
Didn't see.
Yeah, I know. There are multiple pages. Okay, so I would be shuffling between pages. So you can tell me, or since there are 3 of you doing it, I would do it at my pace. Okay. So I'm displaying the screen. I'm starting your time.
Ma'am, next page, ma'am.
Okay. I hope everybody has read.
Yes.
I would suggest you read it and then I would show you the CTGs.
Dr. Ankita, CTGs.
Okay, sure. Room number 4. Next one, should I go?
Room number 5, yes.
Room number 6. Okay, that was your time. Okay.
Ma'am, first, ma'am. That's all.
First one, please.
Okay. Now one by one, you all can tell me. So what have you interpreted from the task? What is it? What type of task is it? I've told you all there are various types of labor ward prioritization. This is.
Ma'am, second,
Can
ma'am.
all 3 of you can unmute.
Second paper, ma'am.
Sorry.
Second page, ma'am.
You still want to see? Okay.
Yeah.
Okay. 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 Are you all ready? Well, I've taken almost 3 minutes now. Hello?
Yes, ma'am.
Yes.
Okay. Okay. So can you tell me what type of task this is? What are you supposed to do? Hello.
Ma'am,
Yes,
first
it
is
is prioritized. I have to
first.
prioritize
Yes,
fast.
yes. This is I want you to register first that this is a prioritization station. If you can see here, it is a prioritization station. Okay. So that's, and I want to know what you have done in the 2-minute time.
Ma'am, one I have written as non-urgent, ma'am, but Jehovah's Witness.
Okay, good.
The second
Good.
I have written as non-urgent.
Good.
Third urgent, ma'am, as she is feeling unwell,
Why?
leaking, choriamnion,
Okay, good.
like that.
Okay.
Fourth is
Okay.
semi-urgent, ma'am. Fourth.
Okay.
I don't know,
Okay,
ma'am.
I would like to say something there. Now, Dr. Manikam, did you know about this station before? This is a recall, I know. But
No,
did you
ma'am.
know about the station?
No, ma'am.
All right.
5.
Because it is given that she is feeling unwell, it is. I'm really happy that you picked that. And yes, it is important to, as I mentioned earlier, there are clues given to you in the labor ward board. Okay,
Yes,
so
ma'am.
this is one such, which we would normally, in that anxiety and the tensed up state, we would ignore this because it's just given that she's feeling unwell. Nothing more is given. Okay,
Ma'am.
so
Yes, ma'am.
this
I want
was.
to.
Yeah,
Sorry, ma'am.
yeah.
I want to add one
No,
thing,
no.
ma'am.
Let me just. Yeah,
Ma'am,
sure.
please talk, ma'am. Talk, ma'am. I'll then. 4 I have. After seeing the CTG, I have written as chronic ischemia. So it is urgent, ma'am. 4.
Okay. We'll come to your room number
Okay.
4. Let me just discuss room number 3. Okay,
Yes,
so this is a clue that is provided to you. So when you go to that room, the examiner will typically tell you that yes, this lady has fever of 101, she has leukocytosis, lactate levels are high, or something like that, for you to know that this could be sepsis. And now you have to talk about sepsis 6, and you have to talk about delivery. Okay, because she's possibly chorioamnionitis and sepsis, and then you would need to deliver her. Okay, in short, of course, you have to say all the sepsis 6 bundle, etc., and MDT and blah blah blah. And but this is in short. So this is a clue which is given here. Okay, she is feeling unwell. Otherwise, why would they mention it in the exam if this had no significance? Okay, so that is good that you picked it. Okay, then go. You said room number 4, chronic ischemia. What is that? Room number 4, previous scar 4 centimeters at 6 hours. Okay, so this is the CTG.
Yes, ma'am. Decelerations.
Yeah. Why is it chronic ischemia?
Deceleration present with a decreased variability, ma'am.
It is early
decreased variability.
Similar one we have seen in the another meet, ma'am. Study MRCOG, they have shown this as this description.
Okay.
I have kept in my mind
Okay,
as
no
chronic
issues, no
ischemia.
issues.
Okay, ma'am.
Oh, okay, fine. Okay, no, see, one thing is you cannot really say there is chronic ischemia based on the CTG.
Okay, ma'am.
Okay, of course, variability would tell you about, would give you a clue about chronic ischemia. Okay, would give you a clue. I'm not debating that. But otherwise, the CTG cannot be just used to tell what had happened in the past. Okay, whether there's ischemia to the baby or not. Tells you the current condition of the baby. Okay, yes, variability, I agree, would tell you about ischemia as well. But if you see, the variability is basically the oscillation of the baseline. Okay, can you see my cursor here?
Yes, ma'am.
You can see my cursor. So
Yes,
it is the oscillation of the baseline, and you have to see across how many beats the oscillation is occurring. Okay, this is 120 here. Okay, this is 130. This is 140. This is 150. Now, if you ask me, the variability here would be around 10 because it is varying from 150 level, this line, to this line. Okay, so the variability is okay. What you need to see when you are assessing variability, that's another mistake that is done, is what is the least count on y-axis. By that I mean each of these blocks on y-axis. This is the y-axis, right? The vertical axis. each of these blocks on y-axis, the small one, the smallest block, like this 120 to this, corresponds to how much? It corresponds to 10 beats, right? Dr. Manikam, you are
Yes,
agree?
ma'am.
This is
Yes, ma'am.
120, this is 130, this
Yes,
is
ma'am.
140, this is 150.
Hmm.
So each of these small blocks will correspond to 10 beats.
10,
So
10.
if it is, what you have to look at is what is the least count, that is what is the what is the strength of the one block on the y-axis, and whether it is oscillating over that and more than that. If it is oscillating over that, over the entire box, you know the variability is at least 10. It may be still more, but it is at least 10, which is reassuring.
Okay.
Right? So, yes, so this, as far as the variability is concerned, it is reassuring. You need to look at the contractions, which are, for you to interpret the contractions, you need to look at the speed. So this 1 centimeter here is 1 minute. Okay. So you have contraction every, say, 5 to 6 minutes. Okay. So she's like getting infrequent contraction. Maybe, although it's given that she's 4 centimeter dilated, but the contractions are not adequate. So, sorry. Okay. So, but that's okay. And there are variable decelerations. If you see, they are variable. While interpreting whether a deceleration is variable or not, you need to look at the deceleration with respect to multiple contractions, because here in this middle one, you can see it looks like an early deceleration.
Yes, ma'am.
All right. So if you just look at this middle one, you will see it is early deceleration. So how to interpret is by looking at all the decelerations, whether it is all the time following that early deceleration pattern or it is varying with respect to the contraction. So like here, here it is coming before the contraction. Okay. Then here it is coming somewhere after the contraction. That means it is variable. So for you to interpret it is variable, you have to look at how the decelerations are occurring with respect to contractions. Okay. So, and you have to see the baseline here, okay, which is around, say, 140 to 1, somewhere in between. So 145, say, or whatever, 140 maybe, okay, which is normal. So there are only variable decelerations. But yeah, but again, as I mentioned earlier, don't just look at the CTG. You have to look at the
Patient.
holistic approach to the patient. So yes, exactly. She's a case of previous cesarean section. You would have, I mean, you would have concerns when a previous cesarean section lady is having decelerations, when she's not having very good contractions. Okay, she did not have such good contractions, but she's still having decelerations. You would want to go in and look at what exactly is happening. You would look at signs of symptoms and signs of imminent impending rupture. You would like to look at her PV. You would like to look at her station. Maybe if her membranes have not ruptured, you would consider doing an artificial rupture of membrane. That would also increase the strength of contractions. You would get to look at the color of the liquor. And whenever required, like if the CTG becomes pathological, you would want to do a FPS. Okay, so that is why you would probably consider a ARM in this particular patient. Okay.
Yes.
Then the next patient. Next patient. What is your interpretation?
5 I have
Room
written
number
as
5.
you, ma'am. As a pre-eclampsia.
Yeah. Why? Yes.
Pre-eclampsia in labor.
Okay.
And
okay.
there is a decreased variability, ma'am. 5.
Okay. Room number 5. Yeah. Okay. Fine. Agreed. Agreed. Okay. Fine. So yes. So decreased variability, and see here again the same thing happens. The variability here is like it's going across the full 10 minutes, but then here there is hardly any variability. It's going almost flat. Okay, so that's definitely a decreased variability, and she's PET, so you're even more concerned. Okay, now I've given you this big long CTG for you to know that this has been happening over a long time, because you can classify it as non-reassuring if the variability is 30 to 50 minutes, and more than 50 minutes become, I mean, it's less. If more than 50 minutes, then it is pathological. I mean, it's abnormal. All right.
Yes.
So that is why I've given you this long CTG so that you know that it is happening over a long time.
Mm.
Okay. So you are definitely concerned here. Okay.
Doctor,
So
Dr. Ankita, sorry to disturb. This is 50-minute trace if the CTG is going on the speed of 1 centimeter per minute. So this is, previous trace is the 50
no, no,
minutes trace because
30, more than 30. 30, right? I haven't counted, but I think I had put it as 30. See, it is
no, so
non-reassuring.
between two markings there is a 10-minute between two markings. So how many minutes trace is this? I just want to confirm that.
Uh, 1 minute. And so this is
Between,
more than 30 here. See, this is
yeah, so
one,
the 1, 2, 3,
one,
4, 5
two,
blocks, 10 minutes.
3, 4,
Yeah.
and
Yeah.
5. So you're getting 50 minutes.
Yeah.
Correct? So
Yes.
this becomes your abnormal. Okay?
Mm.
Okay? So that is abnormal. So you are really worried about this patient. Okay? Even if it was, say, for example, it was not abnormal, it is non-reassuring. Even then you would be worried because she's pre-eclampsia.
Mm.
Okay? Because pre-eclampsia can have IUGR, can already have, now you can say about your chronic ischemia. Okay? So that's the thing. Okay? So this is pre-eclampsia. Hmm?
Yes.
And yeah, so here the CTG is given, and of course, if you had to do the station, the examiner would give you, say, when it was there in the station, that there was some additional information like BP is 170, 110, urine albumin is 2 plus, biochemistry is normal, and rest is fine. So here, what would you do if all that is given to you?
The sixth, ma'am, I have written as semi-urgent, ma'am. +2 station.
You said it
Pushing
was
for 1
urgent,
hour.
right?
She is pushing for 1 hour, ma'am.
No, I'm saying fifth one. Fifth one, you're still on fifth one. What would you do if it is pathological CTG, one abnormal feature? So it's a pathological CTG, 6 centimeter dilated, primary, 37 weeks pre-eclampsia in labor, given to you 170 by 110 blood pressure. How would you answer?
She should be taken for
Answer rule number 5.
emergency cesarean section, ma'am. Already she may be on
Okay. And if,
magnesium sulfate and all. She's on treatment, I think.
okay. Okay. Is that how you would say the answer? How would you answer? Okay, Dr. Manikam, just a minute. Let me give the others also a chance.
Yes, ma'am. Thank you.
Dr. Who was the other one?
Salma, madam.
I'm sorry,
Dr.
I'm not.
Salma.
Dr. Salma.
Yes.
Dr. Salma, tell me. How would you answer
Yes.
it?
So you told that blood pressure is 170 over 110. Urine protein how much?
2 plus.
And PET blood test?
Biochemistry is normal
Normal.
and no imminent symptoms.
No minor symptom. So that means it is
Urine
urgent case.
output adequate.
Educate.
Hmm.
So this is
So whatever,
urgent
first
case.
of all, see, okay, good, go on.
First of all, I'll ask the midwife what has been done now. Is it started for antihypertensive drug, the labetalol, or given the magnesium sulfate? What has been done till now? If not, I'll tell the senior midwife to start it that antihypertensive medication, and also to check her that blood pressure and urine output and protein, close monitoring for that, and conservative management given or not. If not, they can start the conservative management while we are preparing patient for cesarean section, and to stabilize the patient first, and then by this time we can do that FBS. FBS, but
Okay.
then prepare for inform my consultant and prepare for cesarean section and inform theater.
All right. So,
Doctor, can I?
see, when there is a case like this, sorry, who's this?
Yeah, I'm Dr. Shazia. For this patient, just to
Yeah, you
confirm
want
if
to
she
say
has
something.
been given any antihypertensive or magnesium sulfate, and then keep her on left lateral and ask her about any symptoms and
Correct.
do this the
Correct.
fetal scalp stimulation.
Exactly. Very good. Very good point. Okay, so when you are presented with a patient like this, okay, Dr. Manikam, Dr. Salma, first start with your basics. Okay,
Yes.
like you
Yes,
asked
ma'am.
me, what are actually I gave you all the information. Okay, I shouldn't have maybe, but I gave you all the information about her. Whatever is not given, you ask. Like in case I tell you everything is normal, biochemistry is normal, BP is 170, 110, urine
Yes.
protein is 2 plus. Okay, antihypertensive, I don't tell you. But biochemistry normal, platelet count is normal. I have not told you about, say, imminent symptoms. Are there or not? So
Mm.
you
No,
start
you
with
to,
history. Start
no, you
whether she's already on any antihypertensive. History you is important. Whether
Mm.
there are any imminent symptoms. What is her urine output? Whatever I have not
Mm.
said. What is her urine
Mm.
output? Okay. Any of
Mm.
these are abnormal. You know that it is a very severe case of preeclampsia, and you would need to start her on your magnesium sulfate for protection, okay, for
Mm.
prophylaxis. And you would need, if she's not on antihypertensives, you would need to start an antihypertensives right now. Maybe if she's already been given antihypertensives like labetalol, then you may have to think of IV labetalol. Now remember, labetalol, when you say in a structured discussion, you have to say, I would give labetalol provided there is no history of asthma, and
Ah.
initially, if she's conscious, I would give 200 milligram of labetalol followed by 200 milligram after half an hour. If that does not bring down the BP, then I would consider IV labetalol for her. Okay, that is what is recommended in NICE guidelines. So stick to the guidelines as far as the doses and the protocol of antihypertensives is concerned. Okay,
Yes, ma'am.
so
Mm.
that is how you would say this in this particular station. And do not ignore that the CTG is pathological. So you would need to instruct your whoever is going to the station to the this particular room. Remind me later. I will be talking about who all would you would be sending to the rooms. So whoever is going to the room, okay, because you wouldn't be going because there is another room which is more urgent. I'll come to that. Whoever is going to the room, you have to instruct that person to do those steps of what is to be done when the CTG is pathological. If you see my YouTube video, you would know all those steps that are mentioned there. What are the things that you would need to do when a CTG is pathological? Okay, start by saying rule out any acute cause. Here, what I am worried about is abruption. Okay, of course, I know abruption would have an acute deceleration. Yes, so this is more likely to be chronic ischemia, as you said, but still, I would look at acute causes like abruption because the CTG is pathological. So I would like to look at these, rule out these causes. Hyperstimulation, abruption. Hyperstimulation is not there, I know. Okay, then I would also want to look at all those things that you say in pathology. We will be coming to another slide where I'll show you what are the things to say when the CTG is pathological. Like she said, you would do a per vaginal examination, fetal scalp stimulation, discuss with the mother and the about the delivery plan, etc., etc. All those things that you say normally in pathological CTG, when the CTG is pathological, you have to say here in addition to the management of preeclampsia as well. Okay,
Hello.
so
Hello,
that,
Dr. Ankita. Uh, yeah.
yes, yes,
Hi. The thing is that some people have messaged that they are not able to join. Can you check the
all right.
setting, thing like that? Because they have messaged on the group
Oh,
also.
I'm not quite sure why this happened. Um, okay, what should I be doing? Is there anything? Hey, I'm not very good at technicality. It's a free thing. I don't think why they should not ask them to rejoin. Dr. Uma, can you just ask them to join from other device?
Right, sure. Yeah. Let me check.
All right. So, fine. So then, yeah, continuing with the station. So I will be telling you what exactly to be said when the CTG is pathological, and um, yeah. So let's proceed with the next room. Okay, Dr. Salma, can you tell me what is to be done in room number 6?
Dr. Ankita, the previous one I would like to ask you because you know that you told that there is a no
Hmm?
imminent of you told that there is a no imminent of preeclampsia sign symptom. Okay, no imminent, and you told there is
Yeah,
a
yeah,
urine
I told.
output also okay. Yeah. So
Yeah,
do you
yeah.
think that, as I asked, that I'll ask the midwife if
No, no.
laboratory not done?
No, I'm saying in case I don't tell you. In case
Okay,
I don't tell you, start from history.
right.
Okay?
And
Here, that's what I said. I shouldn't have told you everything. So I told you. So in
right,
case I don't tell you, in case the examiner doesn't
yeah,
tell you these
I
things which are
understand.
important for decision making, yeah,
Yeah,
you
I
ask
got it.
from, you start from the scratch. You start from evaluation of the patient in
Okay.
order to understand the management.
Yeah,
Okay?
thank you. Thank
Yeah,
you. And another things I
yeah.
told that conservative management before, when I'm doing the, the preparing for the cesarean section or FBS, they started the conservative management or not. If not, then I'll do. So do you think the conservative management
Yeah,
we
yeah,
should do
yeah.
so many things according to the cause we have to do, like IV fluid, like left lateral
Yes.
position. So do you think we can, if we'll
Yeah, yeah,
explain
yeah.
all of these things, we'll not get time to finish
You'll
other
get
things?
time. Yes, you
Yeah.
will get time. I'll tell you how to say those things. Yes, I'll tell you how to say those things. Because if you remember, if you read your NICE guidelines, in that there is, in pathological, if the CTG is pathological, it is given in a table form. What are the
Yeah,
various
I know.
things, various
Right.
points that you need to say? Yeah.
Yeah.
So those
Yeah.
points you have to practice thoroughly so that you can say them fast.
Yeah.
Okay,
No,
quickly.
conservative
All
management,
right.
we have to tell
Because
details. No, do you think we have to
no, no,
tell
not
details
details. No,
conservative?
there are not details given there. I'll tell you exactly. Okay, because we have one more slide coming
Okay. Okay.
as to
Thank you.
how to talk about
Right.
pathological CTG. What are the things to say in pathological CTG? Okay, so
Okay.
I'll tell you in detail what exactly is to be said. Okay,
Okay.
so
Thank
then, yeah. So next room, room number six. What do you do?
you. Okay. So next, room number 6, it is fully dilated, and she's pushing for 1 hour, past 1 hour. So I would like to see the CTG, which is attached here. Okay. And
Hmm.
she's timing, and she has already inhaler analgesia. Okay, so it depends on my CTG.
Sorry, this is the CTG.
Yeah, so CTG, there is a contraction. Yeah, about 4 contraction in 10 minutes, 4 to 5, I would say 4.
Hmm.
Okay, 4 contraction, and CTG is normal, but I would like to know that she is on syntocinon or not. Okay, syntocinon or not, and it
Okay.
is as she's pushing, so that means she needs to deliver this patient. So CTG is normal, so I'll
Hmm.
tell the midwife to deliver her.
Hmm.
Okay, I'll
Do you
tell the
need to deliver
midwife.
her urgently? I put that slide again. Do you need to deliver her urgently?
Yeah, because
CTG is normal, you said, right?
it is presenting at +2. Okay,
Sorry?
that means plus
Hmm?
2. Vertex is plus
Hmm.
2.
Okay.
So
Okay.
midwife can continue her progress of labor, and she can deliver her. If there is any problem, any concern, to inform me. That's it.
Yes, that's right. Okay. Good. Good. Very good. What you need to
Thank
notice is that she is not on epidural. That is one important aspect
Yeah,
to note when
yeah, no,
she's in second stage. Okay.
yeah, yeah,
Here, as you rightly pointed out, she's not on epidural. She is full
no,
from 6 centimeters, sorry, 6 a.m. She's fully dilated. It was +1 and it was ROP. Now it is 8 a.m. and it is
yeah,
+2, which is OA. And she is pushing for 1 hour.
yeah,
Okay, 1 hour only. That means her active stage is just happened for 1 hour.
yeah,
Okay, active second stage, correct?
yeah,
That's
yeah,
what the NICE guidelines classifies the second stage into, active second stage. The
yeah,
expulsive forces and the active pushing down by the mother is called
yeah,
as the active second stage.
yeah,
So here there is a delay, suspected delay in second stage, active second stage, because NICE guideline says that I would put that slide 1 minute. Let me put that slide because that is another confusing thing that a lot of candidates confuse.
yeah,
1 minute. Yeah, 1 minute. All right. So, yes. So this is what is the active and the passive second stage. Okay. no, I'm not going into details of this, but what I want you to look at is the next slide. That is, yeah, suspect delay in second stage of labor. Okay, for nulliparous, you would suspect delay if there is inadequate progress in terms of descent or rotation after 1 hour of active second stage. Here in this station, she was ROP, then she became OP over 2 hours, but she's active only for 1 hour. Okay,
One.
so here you can, I mean, you can say that you would suspect delay, but it's not something that you would, worry about as of now. You would need to worry about if you diagnose delay. You suspect delay when there is no significant rotation or descent, or the descent does not occur after
Yeah.
1 hour of active stage. Mhm.
Yeah.
For a multiparous patient, you suspect delay if this is inadequate after 30 minutes of active stage. Inadequate. Okay.
Mm.
Now there
Yeah.
are other terms also which I was discussing with my people from the course the other day. Is that arrest of descent? Arrest of descent is taken as in second stage if there is no descent for 1 hour. That is different. That is not mentioned in the NICE guidelines. That was mentioned in Williams obstetrics, but that's okay. What you need to know is that suspected delay in second stage for primary and multi was different. For primary, after active stage or one
Yeah.
hour of active stage, if there is inadequate rotation or descent, then it is suspected delay. For multi, if after 30 minutes, okay, and you would
Yeah.
diagnose delay if active stage, whatever it is, she has not rotated or rotated, even if she's rotated, you would diagnose delay if it has active stage has lasted for 2 hours.
2 hours.
So you cannot really wait beyond 2 hours in active stage of labor. So
Yeah.
if the active phase, that is active second stage of labor, when I say active stage of labor, it means from 4 centimeters, but active second stage of labor, you cannot wait beyond 2 hours, irrespective of how the rotation is occurring in a primary. Okay, I'm not talking about the total duration of second stage. Total duration of a second stage for 3 hours for
3 hours.
epidural is still holding true. Yes, but if for the active stage due for a nulliparous should be considered diagnosed as delay if it is lasting for 2 hours. For a
Yeah.
multiparous, it should be
1 hour.
diagnosed as delay if it is lasting for 1
1 hour.
hour. You should not be, or you should be concerned if active stage, no matter what the rotation is, no matter what the station is, if it is lasting more than 1 hour in a multi, you would be concerned. If it is lasting more than 2 hours in a primary, you would be concerned. So this is what I want you to register. Okay. Then
Dr. Nikita, I have a one question here. They don't give the active or passive question. They just give dilated for 3 hours, dilated for 2 hours. So how we guess then?
uh-huh. Then you have to ask. Just like I told in the pre-eclampsia, whatever
Yeah.
information is not given,
It
you have to ask.
it it is written already. Pushing. Pushing means it is active.
Yeah, here it is written. Yeah, in case she's saying in case it is not given, you would like to know how long the active
How long?
phase has been. Okay,
Yeah.
and if you say that I would diagnose delay if the active phase is for 2 hours, you have to ask that question, and you have to see if the rotation has occurred. Okay, because there is,
Hmm.
see, there a lot of this station presentation depends on your information gathering. Okay, you can ask, you can discuss even if the examiner thinks that you're asking rubbish, don't worry, you ask, and you say that I'm asking this because if there is if the active phase has lasted for 2 hours, I would diagnose delay and I would be worried and I would want to deliver the patient. Okay,
Thank you, Dr.
so that
Nikita.
is how
Got it.
you would present.
Hmm.
Yeah, okay, fine. Then, okay, the next one is room number 7, Dr. Salma. And the last 3 rooms, the other person can do. Room number 7, Salma.
Yeah. I cannot see the. Can you change the slide?
Oh, sorry. I think I had unshared it. Okay, wait. Sorry, yeah.
So room number 7. It is previous history of 2 cesarean section, and she came from
Hmm.
elective cesarean section. So this is
Hmm.
a routine case now, but we have to aware of that. That her ultrasonography will see that there is a placenta position. Yeah, that her antenatal
Okay.
period, the placental position, there is any uh, concern about the placental position. So we have to be careful about
All
that.
right.
And
Good.
also group and safe cross matching should be done. We have to
All right.
tell
Okay.
the midwife to check it. So it is routine case, and midwife can apologizes to the patient that we have urgent case. We can see the patient later on, but by this time midwife can do CTG and to explain to the
Mm.
patient. That's it.
Okay, fine, fine, good. Okay. Now, if you're seeing those things like I would like to know the placental location, etc., etc., say it in a very quick manner. Okay. I mean, don't spend too much time because it is not likely that she would have anything significant there unless the examiner tells you that yes, this is what it is. Okay. So say it in a very quick manner that there would be this is a routine case. If she's, I would like to rule out any obstetric complication. Like a placenta previa in this case, and I would apologize, I would take consent, send routine investigations, and you can send a midwife to this room.
Yes.
Okay. Then can we have Dr. Humaira, right? Next one. Hello. I'm sorry, am I taking the right name? Who was the third person?
Yes, Humaira, I think.
Yeah, I can't find her. Mm. Okay, fine. Okay, then Salma, you can continue with your Dr. Umaira has here. Okay, can you tell me last three rooms? What are you going to do? Hello.
Yes, Dr. Ankita,
Mm,
I'll say or Humaira.
yeah, I think you can say because I don't
Okay,
think we can hear her. Okay.
right. So this is also that type 2 diabetes, and she's 38 weeks. She's for induction of labor. So this is also routine case. So midwife can apologize to the patient that we have emergency case. So we'll explain to her about the induction of labor later on. But midwife can ask her still she's agree to go forward for the induction of labor or she change her mind. And to see the midwife can see also that about the scan that baby weight or to do the CTG. That's it.
Okay. See, again, be very specific because you wouldn't have time to say all those things in one particular room, like her history and all those things. I mean, whatever you said, the previous, there is a way to do it. Okay. Here you just tell what is your immediate management. So here you can say that you would go through records and apologize for delay and take consent, CTG, do a cervical scoring, which you do before an induction, and consider and tell her that it would be delayed. Okay, yes, but the other things, as you said, are important. Antenatal records, then her history, like obstetric history, etc., is all important. What is she taking for diabetes? And so what you can do is before starting labor ward's prioritization station, in the beginning you say in all the rooms, I would like to know if there are any antenatal complications, any medical diseases and any treatment going on, any allergies, any surgeries, what is the BMI, blood group, reservation to blood transfusion, because these are important things that you would need to know in a labor ward when in a patient is laboring or in a patient in for delivery basically. Okay, so
Mm.
not all the history. Okay, just say it in the beginning when you before you start your prioritization. Say it when you're saying, normally a lot of us would tell you to say, okay, so I know that the labor ward is dynamic and this and that. All of that is not carrying marks. Okay, so you would not be ticked for saying, or no
Hello.
boxes would be ticked for saying, I know that labor ward. Yeah, Dr.
Hello.
Umera, we can hear you.
Okay.
Hello, Dr. Umera is, yeah. Wait, I'll give you the chance. Okay.
Okay.
So
Okay.
basically, you would not score anything for saying that, yes, I know that labor ward is going to change and this is what can happen, blah blah blah. That initial bit that you say, do it in a very short manner, short and sweet. Keep it very short, because that is not going to fetch you any marks. What is going to fetch you marks is the points that you make in the station. Okay, so we repeatedly emphasize on saying those points as you do your stations.
Yeah,
Okay,
another
so
thing.
you yeah, just like in if you in our course people, we are tell them, like even in a gynae ward board, I mean gynae ward prioritization station, say all the history in the beginning. Okay, this is what I'm going to gain in history. Okay, and because you don't have to say it in each of the rooms. If you go and say it in each of the rooms, you will not have time to say the specific things in the room. So when you go to each of the rooms, you say the specific things. So
Yeah,
similarly here, you say about the antenatal record, medical diseases, treatment of medical diseases, allergies, surgeries, blood group, blah blah blah. Begin in the beginning, and then as you're doing the station, you just say the specific points in that particular situation.
yeah, and blood
Okay?
sugar also important to know. Now blood sugar is okay.
Yeah, yeah, yes,
Yeah,
yes,
thank
yeah. So that you can say specifically in that particular scenario.
yeah,
Then yeah, the next two rooms, Dr. Umera, you can say.
thank you very much.
Dr. Umera, hello. She's gone again. Hello. All right, never mind. Uh, uh, Fine, Dr. Salman, go on. Okay, you can
Okay,
skip the room number 9 because it is nothing major. It's just like it's in a non-urgent case.
yeah,
Okay, so
non-urgent.
everybody has, yes, so nothing.
And
You
only,
tell me what you're going to say in room number 10.
yeah, Dr. Ankita, 9 also, I would explain one thing, that she has previous IUD. So this patient also, maybe
Hmm.
there is a risk IUD case. So she needs
Yeah,
support also, just
correct.
to aware of that only.
Yes.
Okay.
Yes, but again, let me tell you, don't waste too much time on explaining these things. It's
Mm-hmm.
okay if you can say these things quickly.
Yeah,
Important to say the urgent ones. Okay. So now
yeah,
tell me, in room number 10, you can take, say, the overall station is 10 minutes, right? So first 1 minute is to just start your initial bit, initial history and all that records, etc. Then there are 9 minutes for the rest of the station. So the urgent rooms, you can take maybe 1.5 minute, and the rest of the rooms, say half a minute each. Okay, so
mm,
that's how you
yeah.
divide it. So room number 10, tell me how you're going to say.
Yeah. So this one,
I'm sure
as
you have
it is
identified it as, yes, yes,
three and
correct.
half hours before she had already cesarean section. So first of all, I would like to know her vital sign, and how
Hmm.
is that she has
No, no,
interperitoneal drain,
Dr.
interperitoneal drain two,
Salma, hello,
100 and,
it's not given the time. The time is not
yeah,
given.
5 hours, 5 hours,
Ah,
at
okay,
five
sorry,
hours.
sorry. I didn't see, I didn't. Sorry, sorry, so sorry. Okay.
Yeah,
The drain.
yeah, 5 hours, and drain is
Tell me. So now what
2.5.
you're going to
So it is already three
do?
hours and half. Now 8:30.
All
Okay.
right.
Yeah,
Hmm.
so that means her vital sign could be changed. So that's why I would like to know first vital sign, and uterus is contracted or not, and is there any PB bleeding, and how is
Hmm.
patient muse chart, I would like to see. And
Hmm.
then
Hmm.
there is the interpreter drain 2.5 liter. So how is she now, about drain, how much now?
Hmm.
Okay. And then
Hmm.
what medication should she took till now, and she how much she take any blood transfusion. Mm. So
Hmm.
according to this, it depends on my management plan. So is there any information?
Okay, so it's given that she is hypovolemic. Basically, her pulse is 120 beats per minute and her blood pressure is 80 systolic. So how are you going to proceed?
So that means it is a urgent case. So I'll call for help. Yeah, and I'll inform my consultant. So by this time, I'll tell the midwife that if it is not done, maybe by this time done, that IV fluid should be going on, and also that blood is ready for her, and how much blood she has taken, and 2 white bore cannula, if it is not done, should be, and also cross matching if it is not done. And also that other things, uh, she should be admitted in the high dependency unit to continuous monitoring with a Muse chart. And
Okay.
if I'm busy with other patient, the anesthetist can involve in this case. Yeah. So to stabilize the patient. Yeah. So we'll do ABC. We'll start from ABC. Okay. Airway and breathing and
All right.
circulation. So then
Hello.
syntocinon is
Okay.
started. Syntocinon is started or not? Yeah. So
Mm-hmm.
if not, should be start, and that all investigation, that full blood count, liver function test. So I would like to know first what done. If not done, so I'll do all that I IV line, and also that uh, investigation, the full blood count, liver function, kidney function,
Okay,
and
okay, okay, okay,
endoscopy.
Dr. Salma, let me interrupt you there.
Uh,
Okay, you're
then
taking more than 1.5 minute time. Okay, you're going
then
to be talking about this stage room only. No,
medic,
I'll just,
med,
okay, okay, go on, sorry.
medical management. I'll start from medical management. That synthesis on that if it is not
All
done,
right.
so I'll start medical management, then surgical
Okay.
management, syntocinon and
Hmm.
argometrin after checking the blood pressure, and then syntocinon drip, uh, and carbipost, and that misoprostol. So if it is failed, then I'll go for that uh, uh, that breast suture and cardiac
So,
tamponade. So step by step, I'll do the surgical management. So it depends on her condition.
so this is a case of
Hmm.
intraperitoneal bleed, right?
Yes,
Because
exactly.
brain
Okay,
has
I'm
to be
coming to that.
targeted. So we need to,
Yeah, correct, correct.
after communication,
Yes, yes,
resuscitation communication, we
definitely,
go to relaparotomy. Yeah.
definitely. Absolutely, absolutely. Good. Yes.
And
So
even confirm.
this is how every station differs. So every in every I know this is PPH, no doubt, but in every PPH, you're mentioning your Oxyto 6, all of them will not make sense. Yes, I agree to a certain extent. You will start Oxyto 6 here as well because so much of blood loss will have a component of atonic PPH associated um, because of hypoxia and all those things. But this is intraperitoneal bleed. That means there is something which is bleeding inside. And if it is just PPH arising from a neotonic or atonic uterus, it wouldn't collect intraperitoneally, Dr. Salma. Okay, so she would bleed vaginally if it is atonic. So rather than emphasizing on your medical management, you would talk about resuscitation, and her arrest of bleeding would be by relaparotomy.
Okay.
Okay, so the moment you know that there is 2.5 liters of intraperitoneal drain, that means there is something wrong. Okay, you said about asking previously if she's received blood, etc. No, first thing you would want to know if you were in that situation is how is the patient now? Okay, so what you need to ask is what is the current status of the patient, hemodynamic. Don't try to think about I would like since I already told you that you have to take background information. Yes, agreed, but this is urgent, this is an obstetric emergency. You need to know how is the patient doing right now. So you need to ask, I would like to know her vitals or observations currently. Okay, then I would tell you a BP is 80 systolic. Okay, for you to come to that, it took quite some time. You said that whether her blood was given and all, etc., etc. See, blood was given and all. You're going to talk right now because you know that there is 2.5 liters blood loss. You are going to say blood transfusion, no doubt in that. Okay, but The moment you are informed, say your junior informs you, you are in the labor ward and your junior informs you that there is this particular post-op patient who has a drain which is 2.5 liters. The first question that is always going to come to your mind is, how is the patient? Is she fine? Okay. So assessment of the patient at that moment is the first thing that you should say. Is the observation provided? Then I will tell you observations. The moment I tell you observations, forget about what was already done. You have to resuscitate her now. So you say, this is an obstetric emergency. When you state it, you're catching the examiner's attention. So you declare that this is an obstetric emergency. I would activate the MOH protocol. That's how you say. I would activate the MOH protocol. I would start the steps of communication, resuscitation, sending investigations, and arrest of cause all simultaneously. PPH guidelines mentions these 4 components. Again, if you see my YouTube video, you would know the free video, which is available on YouTube. You would know how to say these things. Okay, and this is important. Remember, if it's a labor ward prioritization station, there has to be a PPH. Okay, and most probably the other room will have a pathological CTG or maybe a sepsis or something like that. But this is very important. So you say start steps of resuscitation, communication, sending investigations, arrest of bleeding, all simultaneously. I would communicate. I would put communication first here because that's very important. Call for help. Involve the consultant, inform the consultant, the anesthetist registrar and the consultant, the porter, the scriber, blood bank. Okay. So these are the people you would need there. And resuscitation, pass 2 wide bore IV cannulae if not already in place. IV fluids, crystalloids, 2 liters, followed by 1.5 liters of colloids, oxygen at 15 liters per minute, lay the patient flat, put the patient, keep the patient warm, consider blood transfusion, so ask for 4 pints of Excels and continue monitoring her on a Meows chart. In the meantime, you send her investigations, which everything is happening simultaneously, remember. So complete blood count, renal function test, liver function test, group and save coagulation profile, and I would consider re-laparotomy for her. Okay, so this is a case of intraperitoneal bleed. So you say all these 4 steps, say how in each of the steps you say who you're going to communicate with, how you're going to resuscitate the patient, etc., etc., what investigations you're going to send, and then you say that I would like to take her up for re-laparotomy because it is intraperitoneal bleeding. Okay, here I have not mentioned oxytocin. Oxytocin would help you, but the urgent thing that you would do is she is bleeding inside the abdomen. She's not bleeding from the uterus. Okay, she's bleeding inside the abdomen. Maybe there is a stitch which is given way, or there is a uterine artery which has given way. You never know. So 2.5 liters is a huge amount of blood. So you would definitely consider a re-laparotomy. It has happened over 3 hours. So, but before that, you have to send investigations, coagulation profile. You would need to give her cells, FFPs, platelets, probably because she may be in the IC already, and then take her up for re-laparotomy. So that is how you need to answer it. Okay, and do not spend more than 1.5 minutes on answering. Okay, so this is an emergency. You pick it up as an emergency and then start by saying I would want to know her observations. Okay, and then the observations would be provided, and then you declare that it is an emergency. Okay, yeah.
Thank you, Doctor.
So,
can I interrupt here a little bit? Can I?
Yeah.
Because sometimes, you know,
yeah, sure.
it is 3 hours and 3 hours, 30 minutes finish. So by this time, you know, maybe so many things done already. 3 hours and 30 minutes, they will not sit without doing anything, isn't it? So sometimes in the
That makes
exam,
sense. Okay.
when exam we are asking that, yes, I would like to know what has done till now. Then examiner, even if it is severe PPH, major PPH, maybe 2 liter blood loss, then he told, okay, now it is normal, patient is normal now, now blood
I know
pressure
why
is
you're
okay,
saying.
everything.
So,
Yeah,
yeah,
so
okay.
that's why I
Yeah, the
asked
thing
you that.
is, there was another, yeah, I know. There's another station, similar station, which had come in the similar room, which had come in the exam, where it was given that there is, it was cesarean done 4 hours ago. Intra-operative blood loss was 3 liters. It is not drain. It was intra-op blood loss was 3 liters. And now it is after 4 hours. So intra-op blood loss will have to be corrected intra-op. That is why it is that way. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. So that is why it is 3 liters. Okay. Okay, what is already done, because now it is 4 hours. You see, you ask what are the observations now. Which the examiner says that the observations are now stable and
Yeah.
intra or blood loss. This is completely different.
Yeah.
That is intra or blood loss. Now it is 4 hours after the surgery. Now she's stable. That means she's resuscitated.
Yeah.
Intra-op, if blood loss is 3 liters, it is quite likely that patient would be resuscitated intra-op while the blood loss is happening, because you're seeing the blood loss on table.
Yeah.
Here, you are finding out that there is blood loss by looking at the drain. So now you want to look at the observations, and you have been told that she is not stable. Understood? So first thing
Yeah. Yeah.
is
Yeah.
observations. Even in
Yeah.
that station, first thing you ask is observations. Once you know that you may think it is urgent, that room is urgent, but once you know that the observations are stable, you would not consider. You would
Yeah.
not consider it as urgent. You would probably consider as somebody who requires ongoing monitoring. So it is semi-urgent, maybe, or maybe non-urgent. But she's probably resuscitated. That's how you think it is resuscitated.
Yeah.
Okay.
Yes.
So yeah, all right. So
But
then the other urgent room is the sepsis, which is basically chorioamnionitis, which I was talking about, which initially we were discussing. Is again, you can, although it is not given in this form, how to deal with a sepsis patient, but it is always helpful to answer an obstetric emergency in this manner: communication, resuscitation, investigations, arrest of cause. Okay, if you have it at the back of your mind, you will organize your answer automatically. If you say communication, first thing, consultant, anesthetist, patient and relatives, senior midwife, and possibly in this case you would also need a microbiologist because it's sepsis. Then resuscitation would be IV line, IV fluid, sepsis 6 bundle, oxygen, antibiotics, broad spectrum. It is important to say broad spectrum antibiotics after ruling out allergies. Okay, and monitor on Meows chart. Investigations would be blood culture, lactate levels, urine culture, vaginal swab because she's leaking, and blood counts, and your CTG, very important, and general obstetric examination, RS examination because there could be pneumonia, and arrest of the cause would be planned delivery. Okay, so if you and consider steroids and magnesium, steroids controversial because it's sepsis, but magnesium sulfate you can say if you are planning a preterm delivery. Okay, so this is how you would organize your station. Whenever there is an obstetric emergency, think of these 4 components: communication, resuscitation, investigation, arrest of cause. On all these 4 components, you need not see it as such in the exam. If it is PPH, you can say because it's given in the guidelines that manner. It's okay if you say it, but say it in such a way that if the examiner realizes that you have organized your thought process. Okay, so it's very important. The reason why it is important to be organized is otherwise it is very difficult for the examiner to understand and to tick mark in the key all those things that you're saying. Okay, so it's important for you to organize the station. Okay, and rest of the things we have already discussed. Okay, so the pathological CTG bit I would be talking about in the next station. So we'll do one more station after this, and we'll do it in a similar manner. We'll split it out, and then we can maybe finish the session. All right. So another important aspect, this was prioritization station. So I would want you to tell me who all are going to which room. Now let me show you the room again, rooms. Okay, okay. You have your ST2. Let me see, show this. ST2, ST1, 6 midwives, senior midwife, anesthetist, registrar. So now you have that notepad with you or the paper where you have written which room is urgent, non-urgent, and semi-urgent, right? So now you tell me, how are you going to assign tasks? Anybody? Dr. Salma or Dr.
yeah.
Yeah, okay, tell me.
Yes. The first one who was his that one Jehovah Witness later never. So this will be midwife. Okay. And
Okay, yeah.
next one is labor ward. This one also midwife. It is non-urgent, so midwife. And then this unwell patient. So this ST2 can go.
Mm-hmm.
ST2. and midwife will be together. And
which one you said?
That unwell, that one, ST2 can go.
Okay, ST2 can go and carry out the initial steps.
With midwife.
Okay.
With initial. But
Yes.
if there is any concern,
Yes. Correct.
he can inform me.
Yeah. Okay. Okay.
Yeah.
Agreed.
And then that one, previous cesarean section and 4 cm CTG attached. So this one CTG is, I think CTG is it variable deceleration, isn't it? CTG?
Yes. Yes. And you
Variable
want to do ARM for her. That is what we had decided. Yeah.
ARM. Wanted to do ARM.
Okay, wait,
Okay.
sorry, not this one. This one.
This one. Yeah. So as can I say that? Yeah. So yeah, this one.
You want to see the CTG?
Yeah, this one ARM. So ST2 ST1 can go. This one ST1 can do ARM, and to check the signs of that scar tenderness, signs of any she should be aware of the signs of scar tenderness, like to continuous CTG monitoring. And so if there is a concern, to inform me. Okay, so ST1 can do this one, and senior midwife should be there.
Okay.
Senior midwife. Okay, and the preeclampsia, this is amniotomy already done. So this is CTG. It is variable deceleration, isn't it? No, reduced variability. This one. Yeah. Preeclampsia.
Reduce variability.
Yeah. So this one. This is the one. I think I have to go this patient. Preeclampsia. By this time I'll tell midwife with me, but I'll tell to start the levodopa and magnesium sulfate, all of these things, that PET, blood test, everything. But after that I'll evaluate this patient. Okay. And then this one is, I told, this is number 6. It will be semi-urgent. This one. So this one midwife can do this. This is semi-urgent case, 6.
Okay.
And then this is previous to see the routine case. This is midwife can see. And this one also midwife, number 8. It is routine. Number 9, it is also routine, midwife can see. And number 10, this is anesthetist, and this is already call for help, anesthetist, and also the informed consultant, and he can come because he is in I think he is in somewhere, this
on the way.
On the way, so he can join later on. And by this time, when PT patient I'll see, I can join also later on, and midwife also there.
All right. Not wrong, actually.
Thank you.
Yes, you would see if there is a PPH, no? Always you would say that you would go to the PPH first. But here the advantage is that she is not actively bleeding from the uterus. She is somebody who requires resuscitation, for which anesthetist can be sent because it's a post-op case. So here this is an exception where you can consider anesthetist would go and resuscitate her, because basically right now you're not going to immediately shift her. You first have to send her investigations. You're going to give her blood transfusion. You're going to give her FFPs, platelets, all those things. You have to correct her coagulopathy, if at all she's in coagulopathy, which is she's likely to be in. And so for that resuscitation part, you can send the anesthetist. But if there is a patient in a room she's actively bleeding, okay, actively bleeding like the von Willebrand disease, there you will always say, I will go. Okay, ST5 will go. Okay, because you would need to do active obstetric management there. It's not just resuscitation. You would need to give uterine massage. You would need to give her oxytocin. So that is your decision. Okay, here, since it's intraperitoneal and it is somebody who requires resuscitation with fluids and blood, you can send the anesthetist there. Okay, which is correct. And you, as you said, consultant, yes, can join there. You can maybe go to the sepsis room see, ST2, ST1 are junior people, so they may not be as trained as even the midwives. So midwives can manage a few things here and there. Like even in the room number 6, who is the CTG is okay, and but there is delay. I mean, suspicion of delay. You can ask the midwife to continue with her. You will go to room number 5, you said. So room number 3, you said, right? The chorioamnionitis patient. Yeah, that's what you said, right? Hello?
Choriomyelitis. Now, choriomyelitis, I told ST2 because ST2 can do blood, everything he can do because it is
Okay.
only
Okay.
blood.
Okay.
Blood
It's,
is
yeah, correct. Fine. Okay.
okay. But I
All right.
told that
All right. It's not
previous
wrong. Yeah. Okay. Okay. It's
previously.
not entirely wrong. But it is better to have a senior person going there because you have there are 3 urgent rooms. The PPH is being managed by the anesthetist, so you are not really worried about it. You
Hmm.
can say you have one extra person. You have the total team is 11 people, including the consultant. So one of the rooms you can send the senior midwife, like the pathological CTG.
Yeah.
Typically, you can send the senior midwife because even in NICE guidelines, it is mentioned that pathological CTG can be reviewed by a senior midwife.
Hmm.
Okay. So, and the PET part can be still managed by the senior midwife. You can ask her to give her labetalol and review her, ask her for symptoms of immunity, all those things you can ask her.
Hmm.
Okay.
Hmm.
So that
Yeah.
can still be done by senior midwife, and and your consultant can join there because she has to be shifted for a cesarean possibly.
Hmm.
You can go to the next urgent. You keep yourself for the urgent cases. Okay, the urgent case is the chorioamnionitis case. Okay, this lady can collapse at any point of time if she's feeling unwell and there is hypotension and all those things, high fever, etc. Sepsis, so they can collapse at any point of time. So you can consider that patient as on your priority. So you can go there. What you said is not wrong as such. Technically, it is not wrong because you need to carry out the basic investigations first, as you said. ST2 can
Yeah.
do that. But
Yeah.
you have to look at multiple things, which the ST2 may not be, competent enough to carry out multiple things. Like you have to resuscitate her as well. If there is hypotension, you have to resuscitate her, you have to provide oxygen and broad spectrum antibiotics, etc., etc. So many things are there, and she's urgent. Okay, so you can say ST5 will go there. Senior midwife to the pathological CTG room with PET, we awaiting consultant, and the anesthetist can go to the next the most urgent room, rather the room number 10. Okay, so these 3 urgent rooms are covered, and then
Hmm.
you can distribute your ST1s and ST2s here and there. And remember, ST1 may not be as trained as the midwife, so midwife can still have, depending on how well trained they are. Okay, so it depends. So you have some 5 midwives with you, so an
Hmm.
ST1 and ST2 and midwife may be at the same level actually,
Hmm.
or even the midwives may be more trained than them. So you do not yet know because it is not given to you how well trained the midwives are over here.
Yeah.
Okay, but pick out the urgent ones and see who's the senior most person you can send there. So if there's consultant goes to one room. Senior midwife is kind of on par with consultant. Okay, so senior
Yeah.
midwife can go there in that preeclampsia.
Yeah.
You will go to chorioamnionitis, and and your anesthetist registrar can go to you. You were right in most of the things that you said, and it is okay that, I mean, it's not wrong if you say it in that the manner that you did, but it is better for you to say that ST5 would go to the sepsis or ST5 would go to PPH. If it is PPH, active PPH, no doubt ST5 goes to PPH. Okay,
Yeah.
fine.
Yeah. So what
All right.
about the CTG for choriomyelitis? This is CTG. What is this? There is no CTG.
Wait. Oh, no, CTG is not given to you. See, all
Yeah.
CTGs may not be given, but you
So
have to
so
say that
that
you would
means
do.
yeah, I told it should be that CTG, how is CTG is going on. So if it is a CTG is normal, that means it is little bit reassuring. CTG is normal. Then
Yeah, it is a bit reassuring. You
because
can wait, but
blood test, everything
yeah,
should be
again,
done. Yeah.
yeah. Right.
Yeah.
Yeah.
Okay. And also another thing that
Okay.
for number four, there is a variable deceleration. You told that there is a suspicious, isn't it? Number 4. So this one also concerning, because there could be sign symptoms of the scar tenderness. Okay, this one also concern me.
Sorry,
Number 4, CTG, there is some concern.
Yeah. So that again, a midwife can handle that, or amniotomy midwife can handle. No, don't worry about that.
Previous history of cesarean section, that one I'm telling you.
Yeah,
CTG,
okay, that's fine. Since you don't have too many hands at your disposal, too many qualified people, just that's you and your consultant is there who can manage like emergencies, and your senior midwife is there who can manage emergencies. But there are so many emergencies, so you can afford to send a midwife to a room that is, see, first of all, scar dehiscence would not present with variable decelerations. That's one thing. But any sort of deceleration in a patient with previous scar, you would be concerned. So first thing you would want to know is how is the Likert status and amniotomy. So that's okay. You can send your midwife there. That's not wrong. All right?
Yeah. Thank you.
Okay. Fine. Yeah. Okay. The last station we'll take, because it's already talked a lot, and yeah, one more on labor ward. Okay. I'll need some more volunteers, and before that, I'll just go through the questions that are here. Okay. Somebody says that she is a little nervous about face-to-face, and Dr. Asifa, hi. Would I need an offline mock? I have been recommended to take with you. Oh, that's nice to know. Thank you. And all right. So this question actually I had answered in the group some days ago about mock exam. See, the whole point about answering a mock exam is to know where you stand. Okay, of course, it gives you a real life situation, how the exam is going to be otherwise. But more than that, it is for you to understand where you stand. Okay, so it's important for you to know your shortcomings and your where you need to, which are the areas that you need to improve on. So yes, you would need a mock where you would get a detailed feedback for that. Okay, when it comes to a mock exam held on site, you are less likely to get a detailed feedback because it is going to be 14 rooms and you're moving from one room to the other. Okay, and the feedback is being given in the middle of the two stations. So there is not much time spent on the feedback in between two stations. Okay, you're moving from one room to the other. It's like a circuit, just like the exam. Okay, of course, it gives you the feel of the exam, no doubt. Okay, if you want to test your stamina, maybe then it's good. But if you want to get a detailed feedback, it may not be the ideal thing, okay, for you to know where you stand. It may not be the ideal thing to take a on-site mock because you are moving quickly from one room to the other, okay, and the time spent on feedback is less because there are 14 examiners arranged for the mock and 14 of you rotating between rooms. Okay, so imagine you cannot spend so much time because one examiner may have a lot of feedback to give. The other examiner will have not much to give in feedback. So, but the time allotted for you is just 2 minutes in between the stations, in between the rooms. So the examiner would just talk whatever he has to talk in 2 minutes, tell you the feedback, and you have to go to the next room for your next station. Okay, so what happens in an online mock exam is that you we listen to the feedback. I mean, we listen to the station, we listen to the recordings, we listen to you while you are doing the station, plus we listen to the recording after you do the station. And we scrutinize each and everything you have said in the station, in the mock exam. And that's when we give you a detailed feedback. Typically, my feedbacks would last, or even Dr. Uma's feedback would last for a time more than the station. Typically, it's more than 10 minutes. Okay, because that is the depth we go to. Okay, our course candidates would tell you that. Okay, so that is how. So that if you want, if you're looking at a feedback from a feedback point of view, go for an online exam. If you are looking at having the real life situation, how the exam is going to be, and maybe the stamina that you are looking at, go for the on-site exam. Okay, so it has pros and cons of both. All right. I hope that answers your question. Okay, fine. So then we'll go to the next station. I would need volunteers here. Anybody, please? Dr. Bismil, where are you today?
Doctor, I'm here. I was thinking that I must say or yes or no.
Okay. Now I can read
Okay,
your
I can.
mind by now.
Yes, yes.
Okay. All right. Dr. Nonier, are you here? Dr. Gigi?
Can I try, ma'am?
Okay, fine. Try. Your name, please?
Dr. Zubia.
Okay. Dr. Zubia. All right. So this is your next station and I am putting your timer for 2 minutes.
Next slide, ma'am.
Wait, huh? Sorry, this is not moving. 1 minute. Huh? Okay, wait. Sorry, just a minute. I'll pause your time. I think there is a 1 sec. Huh? Okay. Restarting the timer. I mean, resuming the time. Okay. All right. Fine. Okay, so I want you to tell me, if you were listening to me in the beginning of the session, I want you to tell me what kind of a station this is and what went through your mind during the 2 minute time. Okay, we are just splitting the station and not doing it at a stretch. So let me know what was going on in your mind in the 2-minute time?
Yes, in the this time I was noticing which is the priority of my patients. I was prioritizing and thinking about the assigning of the delegate the competent team members
All
and
right,
the
good. Okay,
management. Yeah.
fine. What about, okay, what about Dr. Bismil?
I have taken, along with my midwife, taken information from that, and it's not the prioritization. I will go room by room and delegate the task. So I was not thinking about prioritization.
Yes. Okay, fine. Good, good. Okay, I knew you would
Because
know this. Uh, yeah, that's the whole thing. Okay, that was what I think. Doctor, I'm sorry, I forgot your name. Doctor Zubia.
That was Dr.
Hmm?
Zubia. Yes.
Zubia. Okay. So yes, so that is what we had discussed earlier. I think you were not there that time.
Yes.
That
Yes.
it depends on what the. Let me show you the question. Okay, so here it is said that if you read the question carefully, you will get a bit confused because these stations are expected to come in the format, labor ward priority, because they are labeled as, everybody calls them labor ward prioritization stations. But if you go through your recalls for the past 2 exams, they were not really labor ward prioritization stations. They were just a labor ward board that is provided to you, and there would be an examiner asking you, so what are your immediate steps? Just tell me room by room what you're going to do. And then they would give you additional information, a lot of information, additional. There would be just one line about this, about the patient in the station, in the rooms. Okay, and then a lot of information provided. The possible reason why they did it that way is that it is difficult to interpret many charts in online exam. It is very tiring. So what they have kind of modified the stations now, and they are, for the online exam, they are just giving you these type of stations. So this is a typical station that can come for the online exam. Those of you who are answering the online exam, this is a typical station that can come for online, where you are either talking to your examiner and the examiner is asking you, so what are you going to do in each of the rooms, tell me, or you're with the midwife and the midwife has taken handover, or you both are taking handover and you're just discussing with the midwife. So your approach to the station is going to be difficult. I mean, it's going to be different, not difficult, different from the labor ward prioritization. Okay, so it's important to read this task. Okay, so gather the relevant information from the midwife, go through the labor ward board and discuss with the midwife personnel allocation. That means, yes, you are right by saying that what personnel you wanted to know. Of course, for that you would need to know your urgency, but that is not the task about. You would need to know your urgency and the priority because of the personnel you would want to allocate for the task. And what they want to know is the immediate action that you would do in each of the cases. So now this is the room. Okay, so here there is basically, see, it's either it's given to you that it is pathological. Okay, like in this room number 1, para 0, fully dilated 7 hours, and the CTG says that it is pathological, or the midwife will tell you it is pathological. The moment you know that the midwife is with you, you could go in, enter the station and say, hello, I am so and so, I am the ST5 taking handover of the labor ward board. I would be taking handover along with you. Okay, so I believe it's given to you that she's gone through the she's taken handover already. So you say that I believe you've taken handover of the labor ward board. I would like to know more information about each of the patients. I've gone through the board. I would like to know more information about each of the patients, and I would like to know. This is what you would say in this you would say even in the labor ward prioritization. What I was talking about in the beginning of the station, you would like to summarize all the history that you would take in each of the rooms. So you say that I would like to know in each of the rooms, I would check antenatal records, or I would like to know the antenatal. This is check antenatal records, you would say in a labor ward prioritization or a station where you want to discuss, you're answering to the senior, that is examiner or the consultant. Here you say that to the midwife, you would say that along with you, I would like to go through antenatal records. I would inquire about pains, frequency, measures for pain relief, pulse, temperature, blood pressure, urine, vaginal loss. These are taken from NICE guidelines on labor management. Obstetric examination and medical disease, previous surgeries, allergies, BMI, blood group, reservation to blood transfusion. These are the important things which you would say even in a labor ward prioritization station. And not I put this slide there, but I had not mentioned it there. But this is also important in the other station. But the thing is, you need to know that your approach to a station would change. Okay, I mean, it would be like you're taking your handover with a colleague and you're discussing with a colleague that, see, this is what we need to do for these patients. Okay, so you say that you have to be aware. The situational awareness part now comes here, that you have to be aware that you are taking handover with the midwife. You say that, hello, I'm so and so doctor, I'm the ST5 posted on the labor ward, and I would be taking handover along with you. I believe you have taken handover of the patients. I've gone through the labor ward board, and I would like to mm, know more about each of the rooms. In all the cases, I would like to know about, for the patients in labor, I would like to know about the pain, this, that, blah, 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 with the slide that I just showed you. And then you say, in each of the rooms, I would like to know more about their, like, for example, here you can say in the first room, okay, para 0, fully dilated. The midwife tells you that the CTG is pathological. So we need to rule out, all those points in pathological CTG that you would normally say, which I'll be discussing in a bit. Okay, all those points which Dr. Salma was asking in the previous station. Okay, so I'll be discussing, just like how there are points to say in MOH protocol, there are points to say in pathological CTG. Okay, so then the next room would be whatever, para 040, same things that you say in labor ward prioritization with an examiner, you say in a manner that you are talking to a colleague, and basically like you are taking history from her. Okay, you're discussing the history, and then you're talking about the management, immediate management. It's the same thing. Okay, then so these non-routine, non-urgent cases we can skip. I mean, it's the same thing that you would say antenatal records and everything you have said in the beginning of the station, so that's covered. So here you would say that since the labor ward is busy, we would be apologizing. Okay, so me and the midwife are going to be apologizing to the patient and taking consent. We would need to check her cervical score and her CTG before induction. Okay, then that Paravan at 38 weeks arrived in early labor. I would like to check. We would need to go through her records. Same thing actually, basically. And
Excuse
if
me.
there are any high risk factors,
Excuse
and
me,
we would.
Dr. Ankita.
Yes,
Can I interrupt here?
yeah, yeah,
Means
yeah, yeah,
cervical
yeah. Tell me.
score, to check the cervical
Yeah.
score assessment. So do you think midwife can
Uh,
do it, or I'll after finishing my
yes, of course.
emergency I can do?
No, no, no. Midwife can do it. Midwife can do almost everything that an obstetrician should do. Midwives manage labor from 0 hour till delivery. Okay.
Yeah,
So
yeah.
midwife is not a simple nurse. She's a trained personnel in obstetrics. Okay.
Mm, yeah.
So a midwife can do practically anything that a obstetrician can do. Okay. So yes, midwife can do that.
Thank
But
you.
that we have not yet come to that. We have not yet come to the assigning tasks. We are just talking about what we need to, whoever goes, what is needed to be done in each of the rooms. Okay.
Right. Right.
So that is how you would say. Okay. So this is basically I'm telling you the pattern, the way you need to say things. Okay. So now since Dr. Bismil is here, can you tell me in the first room, what are you going to say?
Okay, so in the first room, your patient is para 0 fully dilated since 7 hours, and I have taken over now 8. Now CTG is pathological, so first of all I will exclude the acute causes, which is abruption, meconium, and previous cesarean section in this patient. So after excluding all these 3 causes, I will give her a conservative measures to like left lateral, change the position. If oxytocin is going, stop the oxytocin, correct the hypotension, and again we'll see the CTG if there is an improvement in the CTG or not. If not, give her a fetal scalp stimulation. See, check the response for the fetal scalp stimulation. If the response is good, CTG is improving, okay, we can consider continuation. But if the CTG still remains same, go with the fetal blood sampling, depends on the Bishop scoring. If the Bishop scoring
Doctor,
is, if
the station is she is fully dilated, so she's right occipito posterior and +1 station.
okay, so she is in the occipito-posterior position, +1 station, and she is dilated for 7 hours now. So I would expedite the birth on the basis of pathological CTG. I will do instrumental delivery in the OP position. I will inform my consultant, inform the theater, can take consent from this patient, do the arrangements, and ship the patient to the theater for expeditation of delivery by instrumental delivery.
Okay, fine.
If the
Okay, let me
CTG is not
stop you there.
improving. Hmm.
Yeah, all right, all right. Okay. There are some points you said it well, the pathological CTG, what are the things that is to be done. But again, remember you are talking to a midwife. I'm your midwife. Okay. And
Okay.
yeah, so you are going to tell me, you are going to ask me, see, when you are talking about all those things, no, I would like, you said cervical score. I'm not quite sure what you meant by cervical score. Maybe you meant station, but you said cervical score.
Station,
So
yeah,
cervical score
station,
is the bishop
station,
score.
station. Yeah, yes,
Yeah,
station,
yeah.
station.
Okay. So
Yeah.
don't make that mistake. Okay. So be very clear in what you say. Secondly, it is para zero. So you said previous car, I would need to check. Okay. So these are
Okay, okay.
certain things that you can make mistakes about. But
Hmm.
otherwise, you answered as far as the pathological CTG part is concerned, you answered quite well. Now, let me show you. Yeah, here. Okay. So what you're going to do is you're going to say that both of us, would need to correct any underlying cause like hypotension or uterine hyperstimulation. There's a mistake here. Hyperstimulation. You need to perform a full set of maternal. These are all points which are given in NICE guidelines, which you need to practice to be able to say it in a very quick manner. So perform a full set of maternal observations, exclude acute events like abruption, bleeding, meconium, document a care plan, talk to the woman and birth companion, very important point. Initiate conservative measures initially. Per vaginal examination is, you can ask me, is the findings, are you aware of the findings? Then I would say that yes, it is +1 station, and she is in the right occipital posterior position, when you say per vaginal. Okay. So that is how the midwife will give you additional information. And then you proceed with the station based on the additional information. Then you say, okay, then we should do this. All right. So then per vaginal examination, position station, I told you it is right occipito posterior and +1 station. Yeah. So you say I would check also if there is acceleration with fetal scalp stimulation, and I would anyway inform the neonatologist, I would inform the consultant, and most importantly, when you say instrumental delivery for OP position, you would say instrumentation trial in theater. Very important. Okay. So inform the anesthetist, take consent, and shift the patient to the theater for a trial of instrumental delivery, failing which you would need to consider a cesarean section. Okay, because it's a complicated, it is not just simple OP, it is ROP. So you will have to rotate a bit, +1 kind of mid cavity, and it is mid cavity, so it is going to be very difficult, a forceps. So you would need to do it in theater, you would need to inform the consultant. Okay, yeah, so here, no, yeah, you would need to inform the consultant. Okay, so your assigning can be your consultant and senior midwife over here, because as far as the NICE guidelines is concerned, when the pathological CTG exists, the patient has to be reviewed by consultant and senior midwife. Remember, they have mentioned that in bold, the word and. Okay, so and senior midwife. All right. Okay, there's a question about epidural. Okay, I wouldn't think epidural would be important here. You can ask, it would be important for the instrumentation purpose, for analgesia, but not for decision for delivery. The CTG is pathological. All right, so that is what this is about. Now, if you notice, I have mentioned here query FBS. Now, whether to do FBS in second stage or not is a controversial topic which you can avoid in the exam, because see, FBS can be done if the lady is, say, obese and you think cesarean is going to be difficult, station is high, you think instrumentation is going to be difficult, both modes of delivery are going to be difficult, and you are thinking that the only problem here is the CTG is pathological, no other risk factors for the patient, then you can consider FBS to see if actually there was abnormality. But it is again a controversial thing, because a lot of people ask whether FBS should be done in second stage before taking a decision for emergency delivery. But if it is second stage, if there is pathological CTG, you would hasten the process of delivery, most probably. But if you think that delivery is in either ways, that is instrumentation and cesarean section, both ways the delivery is going to be difficult, then there is a small role that for FBS as such. But otherwise, it's best for you, because you are an ST5, for you to say deliver if there is pathological CTG. Okay, the decision about FBS etc. can be taken by the consultant at his level, because it is kind of controversial. All right, understood,
Dr. Nikita,
Dr. Bismith?
yes, inform senior midwife as well along with the consultant, right?
Yeah. Yeah, so you're talking to the senior midwife, okay? So your senior midwife and see, basically you have to portray how much you know, right? So you have to say that when you're see at the end of this, you can do the assigning tasks, because this is not prioritization station. You can do the assigning task once you have said all of the points in each of the rooms. So then you can say that when you're talking to her about assigning, so room number 1, the senior midwife could go along with the consultant. Okay, because this is the senior midwife that you're talking to, right?
Acha, okay, okay.
That's what you're asking, right? Yeah, yeah.
Mm-hmm.
Okay, yeah. Hmm. Then okay, so the rest of the rooms are, as we discussed, are not very urgent. Room number 5. Room number 5 is, okay, let me go to that board. Room number 5. Okay, what do you think we should say in room number 5? uh,
Should I go
Dr.
or
Zubia?
Dr. Zubi? Yes.
Yeah, Dr. Zubia.
Yes. So in room number 5, as a patient is hypertensive, so I would like to know, ask the midwife about the details of her antenatal record and her current blood pressure, as well as the protein urea. And I will first of all, I will also apologize the patient for being delayed, and I will also see the signs and symptoms of imminent eclampsia from this patient, and then will manage accordingly. Is there any information from this patient?
Yes, she is having her biochemistry is normal. She is having intense headache, and her urine output is normal. She is not a known asthmatic.
Mhm. So, so I will give her antihypertensive. This tablet labetalol will be given at a start to control her blood pressure, and then accordingly, if the blood pressure is not controlled, then I will decide for the further management of going to the IV labetalol or IV any other antihypertensive, and I will check her the reflexes, as well as the we'll give her the magnesium sulfate according to the findings, and check for the consent of the induction of labor, and then the type of induction that is needed, and the Bishop score.
Okay, okay. All right. Fine. So, in your answer, when you're answering about any severe preeclampsia, severe preeclampsia history is important, because you want to know if there are imminent symptoms. So, what are the points that you need to cover? If the midwife will tell you certain things, midwife will not tell you everything. Okay, so you say that because those are the things that are left for you to say. So you say that here again, specifically because there is preeclampsia, you would want to know how long. I mean, it's not given that it is preeclampsia. It's just given to you. It is BP 170, 105. Okay, so you want to know how long she's been hypertensive. Okay, whether she has symptoms of severe preeclampsia, whether she's already on any antihypertensives, and you want to rule out allergies and asthma. You want to know her urine proteins. Very important for you to know whether it is preeclampsia or not. Then again, you would want to know if there is a previous proteinuria, and you would want to do a CTG for her. So that's important for the fetal well-being. Okay, so don't forget the fetus. And biochemistry, RFTs, LFTs, platelet count, and hemoglobin. Okay, cervical score again, Bishop score, and assess the need for magnesium sulfate. Now, if she says that she has severe headache, then you would say that she would be offered. Okay, so say offered. The word uses offered is better than I would give. Okay, so you say that she would be offered magnesium sulfate, and when there is a important drug mentioned in a structured discussion, it is important to say the dose as well. So 4-gram IV loading dose, stack then followed by your 1 gram per hour. You know the regime that is typically followed. Okay, so these are the things that you have to see. Typically, a preeclampsia station would come in the exam. So when the BP is high, don't assume it is preeclampsia. It could be chronic hypertension as well. So you need to look at her urine proteins. And if the urine proteins are given to be high, you would want to ask if it was always high or it is a new onset proteinuria, because that will then definitely tell you about whether the patient is preeclampsia or some underlying renal cause or something. Okay, so keep those things also at the back of your mind. Okay, so urine proteins, signs and symptoms of severe preeclampsia. Labetalol you would need to give tablet if she's conscious. Tab labetalol after ruling out asthma and allergies, and after half an hour. If that doesn't work, then IV labetalol would be needed to be given. CTG for the baby, cervical score, biochemistry, renal function test, liver function test, platelet count, hemoglobin, and I would consider magnesium sulfate. Now you are the ST5, so you say I would consider, because you have to discuss with consultant. So I would consider magnesium sulfate for her, and that is a 4-gram IV and your dose. Okay. Then so yeah, so that is what it is. Again, there is a question about prioritizing. Yeah, see, Dr. Kalpana, again, I'm not sure if you joined in late, but this is what we've been talking about. Whether you have to prioritize or not is given in the station. All stations are not for prioritization. Okay, so this station is where she's discussing management of each of the rooms with the midwife. Okay, so she's discussing each of the rooms with the midwife, and another task that is given here is your assigning tasks to the team. So for that you need priority. For that you need to know the urgency, but that can come later because you're going to assign tasks. Okay, but if they say that you have to prioritize, then it's better for you to prioritize first and then talk about the urgent rooms and assigning tasks. Okay, Dr. Kalpana? So it depends on what the question is. Okay, so this is the question here. This is the question. Gather relevant information from the midwife. Go through the labor ward board. Discuss with the midwife personnel allocation and immediate action. So that is what it is. That is what she's doing. Okay. All right. Somebody asked about partogram. Can you elaborate on which room was the partogram needed? Dr. Mridu? Yeah.
Yeah. In any patient, if she is an active labor or she is not progressing or where we are suspecting delay or arrest, then we have to look an overview of partogram also, that whether she is she was progressing or
that is
what action
routine.
taken like that.
Correct. That is routine intrapartum care. Okay, the partogram is considered as a routine. Yes, you can say partogram in the beginning when you are talking about general history and general things that you're going to do for all patients, which we have said. Okay, general points. Basically, there you can add the point about partogram in active labor. Okay, so you can add. Then somebody asked
And
about uh,
and ma'am,
something
one more
and
doubt. Regarding
huh,
fluid management in pre-eclampsia, we have to involve anesthetist
yeah,
also. In
not needed, not
pre-eclampsia,
needed.
there was in last
Preeclampsia is,
discussion.
yeah, you
No,
can involve the
pre-eclampsia with
anesthetist as long as there is an anesthetist available. Yeah, as long as there is anesthetist available, I mean, at your disposal, and as long as there is no other room which is going for a cesarean section, you can involve the anesthetist as well. But remember, preeclampsia is for you to manage, and a lot of candidates say, I would say, an anesthetist in the room with the lady with high blood pressure, but I don't see why, because preeclampsia is not never managed by anesthetist primarily. The first management is by an obstetrician. Anesthetist would be involved when there are complications, or when she requires ICU care, or when she requires a cesarean, or your fluid management also you would know. And fluid management, in case she has pulmonary edema, yes, you would involve your intensivist, but not always. Okay. So I think that answers your question, Dr. Iqbal, as well. All right.
Dr. Ankita, I see here in this board, if we do prioritize, then room number 7, where the blood loss is 2 liter within 15 minutes, so I will go there, okay? This is most urgent.
Yeah. Yes.
Okay,
You will go
so
there.
room number 1, where there's a pathological CTG, senior midwife or ST3 can go there, okay? Room number 5, where there is a preeclampsia. Now here, where the second most seniority is the anesthesia registrar. So can we send registrar here, or we shuffle registrar from this room?
Room number?
5. See,
No, room
we
number
send 5.
ST3 you're sending to 5, right?
No, see, room number 7, where the where there's a major PPH, I will go there because I'm
Yeah,
the senior most.
you
Okay.
will go there. Correct.
Yes,
Yes.
yes, correct. Room number 1, where the pathological CTG is there. Okay.
Yeah,
So here
yeah,
I'm sending my senior midwife or ST3.
yes.
Okay. So
ST3 will go to PET because there are 3 urgent rooms, no? So you
yes,
can send the ST3 to PET. Consultant would be arriving. So you can send I mean, you can send as in you can request the consultant to have a look at room number 1.
so where we should utilize anesthesia registrar then?
There
Anesthesia
is
registrar in you can ask the anesthesia
there
to
is
review room number 10, which is a
number
post-op
10.
case.
Yeah, number 10.
Yeah, review
Okay.
room number 10. Room number 10, this is the one which you were talking about, Dr. Salma. This is the
Yes,
lady where there
yes,
is intra-op blood loss of 3 liters.
yes.
Intra-op, this is intra-op, that is not the drain.
Enough.
Okay,
Mhm.
and now it is already 4 hours past, so she's probably resuscitated. But you have to
Yeah,
ask initially what are the findings, because she can
yeah,
still be in shock. If she's in shock, again, it
yeah,
is an emergency.
yeah,
But if she's stable, once the
yeah,
midwife tells you, oh, no, she's stable, then you say
yeah,
that you can send your anesthetist registrar to review her.
yeah,
See, anesthetist register will also be required for your cesarean, dear. So
yeah,
it's not like the anesthetist registrar is not is unoccupied. Anesthetist registrar also would be going for the cesarean with the room number 1, but before that she or he can review the patient room number 10.
yeah.
Okay,
But if it is stable, no need now. If it is stable, if they will tell no, now patient is stable, no problem. So then later on they can, after emergency case, later on anesthesia can see. But by this time midwife can see her closely monitoring and
correct.
everything. If there
Yes,
is a concern
absolutely,
to inform.
absolutely,
Thank you.
correct, absolutely, yeah. All right. Okay. So room number 7, can Dr. Zubia do it? Again, I want you to follow the instructions given in the previous station. If you were there, I'm not sure if you were there.
Yeah.
Room number
So,
7.
Yeah,
Okay.
room number 7, the patient was delivered 15, it was 8 hours, yeah, it was, she was delivered 15 minutes back and she has a blood loss of 2 liters. So it is an obstetrical emergency as this is a case of primary PPH. So I will call for help and involve the consultant as well as the anesthetist and the involve the hematologist in the blood bank and arrange the blood and after grouping safe. And after reviewing her all the uh, recordings of blood pressure and taking all the vitals and looking for the after the meal start. I will start the IV fluids at the crystalloids and the colloids, and then if there is a need of blood transfusion, then after ruling out her Jehovah's Witness, I will give her the blood products. If it is group and saved available, then this the cross match blood is available, then I will give the cross match. Otherwise, O negative, Kel negative blood can be given to this patient, and then and at the same time resuscitation as well as the communication and we will go on simultaneously, and I will see the cause of the blood loss in this patient. If it's the tone that is because of the acetone, I will start the utrotonics and then manage accordingly to this patient. If the medical management is fail, and I'll go for the surgical management in this patient.
All right, good, good. Okay, so as we said in the previous station, PPH, major obstetric hemorrhage. So yes, this is what you need to say. Okay, say those 4 components in the beginning and say it is an obstetric emergency. I would like to activate the MOH protocol. Say the 4 components and all of that right in the beginning and elaborate each of the components. Okay. But
Okay,
you
ma'am.
said most of the things. So yeah, so resuscitation, airway, breathing, circulation, IV line, blah, 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 blah. And you know this is the major hemorrhage and she will be in shock because it is given that she has lost 2 liters in 15 minutes only. So it's like losing 1/3 of the volume in 15 minutes. So that's quite bad. So again, that's the room which you have to go to. Okay.
Yeah,
Fine.
ma'am,
So
because of the
similarly, there
time
was another
constraint,
station.
like we can't say much as this is a PPH, we need to debrief, document, and everything needs to be said. But because of the time
No, no, no.
constraint,
Debrief
yeah,
document is debriefing and all is later management.
yeah,
This what they are asking in labor ward boards is what is your immediate management.
yeah,
So
yeah.
you have to talk about the resuscitation part.
Okay, okay, thank
Okay.
you. Yeah, ma'am.
So yeah. Next room. Can you tell me what you would say? Next room number 8.
Yeah, this patient is para 2 and she is 9 centimeters in active phase of labor. So I will ask the midwife about for how long she is at 9 centimeter and review her partogram and as the CTG is showing the typical variable decelerations for 30 minutes. So I will go for the fetal blood sampling for this patient and then manage her according to the sampling reading. If there's abnormal again, then I will prepare for the cesarean section, emergency cesarean section.
Can you classify the CTG?
Yes, no, it is the suspicious CTG. I think I'm
Uh,
choosing this. Yeah.
No, not yet. Not yet. Because it's given to you that it is typical variable deceleration for 30 minutes. For you to classify it as a non-reassuring feature, typical variable deceleration should last for 90 minutes. Okay? So
Okay.
basically, in this case, you cannot as yet classify the CTG. Okay? So, no, Dr. Mridu, there is no role for intrauterine resuscitation.
So, do we
Somebody,
need
Dr.
to ask
Mridu is
like
asking
to
about
inform the midwife
intrauterine.
to continue the CTG for further 60 minutes? Is it?
Exactly, correct. I mean, don't say 60 minutes. See, and again, don't go strictly by CTG. If there are other things in this case, like she may be bleeding or she may be having meconium, does she have, a question should be, does she have any high risk factors? Because the one of the uh, major points that you should look at when you are interpreting CTG is whether the patient has any underlying risk factors. Okay,
Yeah.
so if there is any underlying risk factor, even a variable decision for 30 minutes also, you may not be very comfortable, like if she's bleeding or if there's meconium. Okay, so you may not be comfortable. You want to know if there is an underlying risk factor. If there is no underlying risk factor, you will continue monitoring with the CTG. If there is an underlying risk factor, you will have to review. It's not like you have to do some intervention. You will have to discuss with the consultant, etc., etc., and then take the decision. Okay, you would have to review her situation. Okay, that's what you will need to do in this case. Okay, yeah, this is reassuring feature, correct. All right, so our next room is nothing much to say. It's just like the previous station where we discussed para 1, living 0, previous IUD. So probably you would need to know what was the cause of the previous IUD and how is she, her mental health status, etc. And apologize that there would be delay and do her CTG, send her routine blood investigations and her consent and a cervical score and wait. Okay. And the last room, as I mentioned, she would probably, when you ask the midwife, what was the, can you tell me her observations? Midwife would say she's stable. Her pulse is 90 beats per minute. Blood pressure is 110 by 70 and she output is adequate. Then you say that it seems that the patient is resuscitated already. So I would like to continue monitoring her on Meows chart and preferably in an HDU. Okay. So that is about it. All right. Is that very clear to everyone?
Yeah, ma'am.
Doctor,
Like
I
we
have
have to
one
say like
question.
this that I will ask the midwife to the examiner or directly to the midwife. Like examiner will be pretending as a midwife.
Yeah, exactly. Correct. So you have to ask to the examiner in a very polite manner. You say, could you please tell me what are the what are her observations? Okay, so that way.
Okay.
All
Okay.
right.
Yeah.
Yeah. Yeah. All right.
Doctor,
Prankita,
Okay. Any other
where
question? Yeah. Yeah.
Ma'am, hello, ma'am.
Yeah.
Hello, ma'am. Ma'am, I have a
Yes.
doubt,
Yes. I'm
ma'am. Room
listening.
number one. Yeah, ma'am. She is a primary gravida at one, fully dilated for 1 hour. She's showing CTG pathological. If we do this fetal blood sampling, if it found to be normal, we can wait, no, ma'am. Or we can, if because she's the primary with 1 hour of full dilatation, we can wait even 2 hours, no, ma'am, in the active phase.
Your voice is, sorry, Dr. Prasanna, your voice is breaking a bit. Can you just repeat that, what you said?
Ma'am, she's a primary fully dilated for only 1 hour. Hello?
Yeah.
Hello, ma'am. Yeah.
Yes,
So
yes.
the CTG is pathological. If even with the fetal blood sampling is normal, we can allow her because she's at +1 station. We can allow for
Yeah.
vaginal delivery without instrumentation.
Yes, but it is pathological CTG. Again, FBS, as I mentioned, is kind of controversial unless she has risk
Oh,
factors and for delivery. So it is when the CTG is
oh,
pathological, it is best to deliver when she's already in second stage of labor. Okay,
okay,
that
ma'am.
you
So
can put that
practically.
thought across. It's not wrong. Yeah,
Oh,
it's not wrong if you
okay,
say
ma'am.
that since the instrumental delivery can get complicated, I may have to discuss about FPS with the consultant. Again, say it in this manner.
Yes.
Okay, be very
Okay,
careful
ma'am.
about the controversial things. Okay, so you say
Oh,
that I would since the CTG is pathological and the position is it's mal position, so it's unfavorable for an instrumental. I mean, it is unfavorable as in it is going to be a difficult instrumental delivery. I would like to discuss with my examiner about the possibility of an FBS and if at all can be possible and otherwise it is quite likely that the delivery would have to be, the words that you use is important, that the delivery
yes,
would
ma'am.
have to be expedited. Okay, so in this case you would need
Yes, ma'am.
to possibly expedite the delivery. Okay, yeah, so
So,
any
Dr.
other
Ankita,
question than that?
yeah. So in this case, like fetal blood sampling, so it will take further time, and already CTG is pathological. So that's why I think we should not comment more on fetal blood sampling.
Yeah, that's exactly. It's a controversial issue. You do it
Yeah,
only
yeah.
when there are you contemplate difficulties with well as instrumental delivery. Then there may be a role for you to wait and watch and all that. But when this is already like this, you would not, I mean, you would not really wait. Okay, so that's how you should
Yes.
say.
Yeah. That was my point. Thank you.
Dr. Ankita, excuse me.
Okay. Mm-hmm.
Just first, when you explained that about the face-to-face exam, the consent paper we have to, there is a, if it is teaching session. So, do you think that so face-to-face we have to write it down everything that consent paper what practically is done. So I have to do same like so I have to fill up in front of examiner and I'll sign everything and
Yes.
yeah.
Yes, yes. You don't have to see, they are not going to read your consent papers. So when you're talking about the frequent risks and the other that serious risks, you can just scribble on it. Pretend like you're writing. Okay, scribble on it. They're not going to read it as such. But you have to put it across that you're writing it. Okay. Scribble in a
Yeah.
very, as you are saying, it's possible to do it. As you're saying you're high risk, you can
Mm,
write it down. And
mm,
important is to your sign should be there. The patient sign should be there. Patient's name and NHS number and or details, age has to be written. That is
mhm.
important. Okay.
Yeah. Now I have
Okay.
to
And
tell
as
or
you're
I have
saying,
to
the
write also
intended
same
benefit.
time. I have to
Yeah,
write
yeah,
same time.
yeah, yeah. You have to write at the same time because otherwise
Okay.
it will you would be wasting time.
Right.
Okay.
Thank you. Yeah. Thank you.
Uh.
And
Okay. Okay.
another question that if any patient laboral prioritization for emergency for cesarean section, maybe elective cesarean section. So previous 3 cesarean section. So I'm the one I'll do this cesarean section. So after finishing the emergency case. So do you think I have to take the consent to explaining the patient, or if ST1 or ST2 they are sign up for that, they can do that?
Yes, yes. They are signed off. They can take. If they are signed off, they can take. ST2 signed off can take definitely.
Thank you.
Cesarean
Thank you
section.
very much.
Yes.
Thank you very
Yeah.
much.
All right.
Hello,
Okay. So
ma'am.
there is a question here about. Hello. Yeah. Okay.
Ma'am, other than NICE guideline, is there any other source where we can have better grip on the CTG, like multiple traces or something? Any sources you
I
will
would say
suggest?
our library. Okay. I would say our library. Anyway. Yeah. So yes, there is in fact there is a video on CTG as well that I have done. And you can access that as well. And um, mm, nice guidelines is a comprehensive source for CTG, no doubt. And more than that, you don't need to know anything else. Okay, you just have to know your Dr. C bravado, how to interpret, and what is the speed of CTG is also important for you to understand what is how long is that abnormality persisting. Always look at the contractions. Don't forget. Look at the baseline because sometimes there may be tachycardia and you may miss it thinking it is normal baseline. Okay, so just stick to the basic principles. Nobody is going to ask you all those, those W pattern and this and that. They're going to basically stick to basics, right? So yes, so NICE guidelines is a comprehensive source of for CTG. All right.
Okay.
So, okay, there is a question about MRCOG, that is our new platform that we have launched by Dr. Arshia. So, yes, as I would be very happy to be talking about it because I'm really proud that we have launched this particular platform for all of you. And we have really, it's our baby, as we call it. Dr. Uma and I have done this particular thing. Basically, what it is since you asked, let me tell you that we have basically done stations, okay, online stations, and we have put those stations up. We have already recorded 150 stations. They are being uploaded constantly on the. Let me mute everybody. Okay, so we are constantly uploading it on this platform. We almost have reached 100 stations already on the platform and uploading constantly more. And this is going to be a very comprehensive resource for all of you. You know, you can refer to it for while you are doing stations.
So I
And
think she also asked about
yes, I'm
showing.
doing. Yes, that's what I'm doing. Okay, so yes, as Dr. Uma says. So this is what it is. And so there are various modules. All these stations are arranged module wise, and we have managed to finish all the recall stations in this resource in 10 minutes. All stations are done, including labor ward prioritization stations and negotiation stations and whatever that most candidates find difficult. Okay, so just to show you a bit of a clip of one of the stations, it would be something like this, where you would have uh, both of us doing the station. So this is how it would go. All right. So okay. So basically, it's the role play that is going on. All right. So this is available as a new platform, and yes, thanks for bringing it up. And that's because I'm really feeling good about having launched this particular platform for our MRCOG aspirants. And I really hope it would help all of you in the future. And I wish all of you all the best for the upcoming exams. And yes, keep practicing is all I have to say. In the last month, please just practice. All right, Dr. Uma, are you here? Since you're here, do you want to add anything?
No, I think I was not there for a bit in the middle. So you've spoken about face-to-face versus online, I suppose.
Yes, that was done in the beginning. Yeah.
Okay. All right. Yeah. So for those of you who are already using MRCOG, leave us personal direct reviews if how it has been helping you. And yeah, I think that's it. We've seen significant improvement with our own course people who have been using this
Yeah, a
particular.
lot, a lot.
So I think that's all.
All right. So thank you for your patient listening, and so we wind up here. Happy studying.
Dr. Ankita and Dr. Uma.
Idea.